Dr. Baishak, you can go ahead. Yeah, Dr. Baishak, are you online?
Hello, am I audible,
Yeah,
sir?
go ahead.
Hello.
Yeah, go ahead. Go ahead.
Yes, yeah, I'm Dr. Baishak. I'm right now consultant in Medical College in Kochi, MIC Medical College. I did my MD from MIC Medical College and DM from Trivandrum Medical College. So, let us have a good discussion.
Yeah, Dr. Krishnamohan.
Good evening, everyone. Myself, I am Dr. Krishna Mohan. I am currently working as consultant neurologist in Visakhapatnam, and I have done my DM from Sri Chitra Trinal Institute in December 2023. Yeah, hopefully we'll have a good discussion like yesterday again.
Yeah. Yeah, Dr. Ekta, you can go ahead.
Yes, sir. Good evening, sir. I'm Dr. Ekta, DNB Neurology third year resident at Zydus Hospitals, Ahmedabad. Can I start, sir?
Yeah, go ahead.
There is some muffling of sound from your end.
That is the
Is
YouTube
your
live, sir.
internet?
I have shared the YouTube live also. Okay.
Okay, okay. Yeah, you
Okay.
can start.
Okay, sir. Yes. A 59-year-old female patient, right-handed, married, housewife, studied till 10th standard, residing at Baswada, Rajasthan, informant son, presented with chief complaint of inability to do routine activities since 2 years, personality change since 1 year. As per her son, premorbid personality of the patient was extrovert, pleasant, and social. She liked cooking and tried to make new recipes.
Yeah, go
Dr.
ahead.
Ekta, yeah, do you
Yeah.
want do you think the pre-morbid information is enough, or anything more you want to add usually?
So her hobbies are to like she's a housewife, so she does a routine course, cooking, buying vegetables from the vendor. She liked cooking and she tried to make the new recipes. Else than this, she liked to get social with the neighbors.
Yeah, that is good. But I
Can
think you always try to tell what the patient does from uh, morning since he wakes up till evening. If you cover all those things, then we can try to ask the questions accordingly.
Okay,
Know what is the routine of the
okay, sir.
yeah.
yeah,
Okay,
routine has
so
to be.
she gets up. Okay, sir. Okay, so she gets up at the 6 a.m. Uh, has like performs bathing and then makes tea for herself and her husband. Then she prepares breakfast for the whole family, which includes the patient herself, her husband, her son, his daughter, her daughter-in-law, and the grandson. And then she goes to the market to buy the vegetables uh, for the preparing the lunch. Then she comes home. Then with whatever like wash clothes are there, she like she'll fold them. Then again in the noon she'll sleep. Again in the evening she'll prepare tea, and then she'll prepare for the evening dinner.
Can go to the next the history.
Yes, sir. Patient was relatively asymptomatic before 2 years, after which family noticed that she started developing difficulty in performing day-to-day routine activities. It started with making mistakes in the cooking, as she was not able to judge the correct quantity of the food. She used to prepare food for 5 people, but now prepares in the large quantity. Later, she started forgetting to switch off the gas stove. There was no difficulty in handling tools in the kitchen. She also started developing difficulty
You can
in.
you can discuss the first complaint and then go to the next one.
Okay. Okay, sir. So initially it started that she wasn't able to judge the correct quantity. So her daily routine was to make the food sufficient for the 5 people. But now she uses more duff to prepare the rotis. She's preparing quantity in the large amount, which as compared to previous.
So, what does
But
it mean?
Sorry, sir.
So what does that mean?
That she is not able to judge. She is um, having she is inattentive.
You cannot tell inattentive. Nobody is like somebody is inattentive. They won't make large quantity indoor. This is basically a judgment error. No, he doesn't have the ability to judge
Yes, she
how
is
much
unable
quantity
to
to
judge
switch.
the
And whether
quantity.
there's a,
Yes.
whether there is any like any taste difference in the or change in masala or change in taste, so, and the time consumed for cooking, any change in that.
No, sir, they didn't complain of that thing of sequencing errors initially.
No, not sequencing error. Just like the patient takes like the patient had dementia. He's trying to cook. She takes too much time, but she cooks relatively okay. And another person who takes less time and complete it very fast, but with lot of errors. Any difference in that?
Sir, I'm unable to hear. Sorry, sir.
Yes. If a patient is that like she is able to cook relatively okay, but she consumes lot of time to cook the same amount of food. But another patient who is having again dementia, and she cooks like very fast on the usual time only. But there is lot of difference in the taste of the food, and she is difficult in cooking. Any difference in these two patients? What
Okay, so
happens?
initially, sir, in the first thing where the person cooks the proper food but takes the long time for cooking, there is a slowing of the activities. And in the second thing, there are mistakes while cooking.
Slowing of activity, you mean about Parkinson's? No,
Yes, sir. Yes, sir.
no. It's actually cognitive. So that slowing of cooking and with reasonably okay food, that means it is more of subcortical dementias. Because subcortical dementia, they can
Okay.
take cue and correct themselves. But cortical dementia, they
Yes.
will have problem with the cortex, and they may do the activity, but it will not be the exact activity what they're doing, but they don't have the proper insight of what they're doing, and they may commit errors and continue with it. They don't take cues
Yes,
and
sir.
correct it.
Yes.
So
Yes, sir.
here he is having maybe a predominantly judging, or maybe if there's a planning error or something like that, there may
Planning.
be some more
Yes, sir.
time consuming, some more extra
Yes.
time consuming.
Yes.
And if it is
Yes,
because
sir.
of like she's having problem with finding out the masalas, the taste will be different. So you have to explain all those things in the same question.
Okay. Okay, sir. Yes. Later,
Question,
she
sir?
started forget.
Where do you want to localize those two that currently?
Okay, so the error in judgment will be localized to the dorsolateral prefrontal cortex.
Okay.
Later, she started forgetting to switch off the gas stove. There was no difficulty in handling tools in the kitchen.
So what is forgetting the switching of the stove, and what
Uh,
happens after that?
s-
Whether uh,
okay, so, sir, the patient forgets to switch off the gas stove, means the recent memory is involved, and
can be.
there is
What do
no
you mean,
difficulty in
what,
handling tools in the kitchen.
what do you mean by recent memory? Like you want to say what is that involved here in the forgetting the gas stove? This is
Sir,
more like
the
yeah. Go on, go on.
okay. Uh, huh. Sir, again, the dorsolateral prefrontal cortex for the
No,
immediate
no.
memory.
So whether it
Right.
is immediate memory or anything else can also occur. It may not be just immediate
Uh,
memory. It
huh,
can be something also.
like she's maybe she gets confused.
But she was doing the
She's
cooking normally,
inattentive.
yeah, inattentive. That
She
can also be
inattentive.
very,
Yes.
Yeah.
yeah, very common is like many times you will misplace something. It will be most of the persons like those have anxiety issues, those have other issues, or they have stressors. They will do the same thing. They will forget to certain things. That is predominantly because of attention. That may not
Okay,
be
sir.
dementia.
Okay.
That may not be memory loss.
Okay, sir. Okay. Okay, sir.
So what happens after that? Whether the gas stove is switching, like if she forgot to, whether suppose she has kept some tea on the gas stove, and he kept it there, and after some time she only will come and stop it, or somebody else will come and close it and ask her what happened to the stove.
Sir, after someone else will come and switch off the gas stove.
Okay. Then if they ask her that whether they had like why you have not switched off the stove, what is her reply?
Uh,
Can they ask her?
I forgot it. I was unaware of it.
Okay. If she is denying that I had not done it,
No, sir, she is not denying.
okay. Any difference in those things?
Yes.
Like if she denies that I have not done it,
There is there is lack of insight.
may not be inside. It may be if the patient has significant memory loss, they will deny that I have not done it. But if it is
Yes, sir.
attention, they will remember that what has happened. And second
Okay.
thing is denial of inappropriate behavior, particularly seen in urination, can be predominantly from the right side.
Okay. Okay, sir. Yes, sir. There was no difficulty in handling tools in the kitchen.
Okay.
Okay, then
Uh, she also
My
started developing.
my voice is
Yes,
not
sir.
clear, right? My voice is not clear.
Yes, sir, it is audible, but it's not clear.
Hello.
Yeah, now it's clear.
Okay, I think it's problem with my headset. Okay.
Can I continue, sir?
yeah, continue.
She also started developing difficulty in managing money. Previously used to pay the bills of milkman, maid, vegetable vendor, but now makes mistakes. She pays 100 rupees instead of 10 to the vegetable vendor and switch the bills.
Yeah, explain then. What do you think of it?
So could be due to the calculation errors. Maybe because she is inattentive, so she's switching the bills.
Okay.
Uh,
No, those are definitely possible. Then what else can be?
Maybe she's forgetting that the vendor told her they are that it is 10 rupees.
Yeah, that is inattention, right? You already told.
Yes, yes, sir.
Right?
Yes.
Maybe she's having problem uh, identifying the note.
Yes, sir. Yes, could be.
Yeah. Then so the first thing it can be most commonly it is because of inattention, right? Second
Yes,
thing is
sir.
she's not able to identify the note. Rather than the
Notes. Yes, sir.
calculation difficulty,
Calculation mistakes.
yeah, calculation mistake is also possible. But if you, when you tell calculation difficulty, suppose patient gives 100 rupees and she's taking 80
Yes.
rupees instead of 90 rupees, then it's a calculation difficulty. But she's giving 100 rupees and she's forgetting it, right?
Yes, sir. Yes, sir.
Not bothered
Okay.
about to take the change back.
Yes, sir.
So there
Yes,
is
sir.
there is no calculation in that actually.
Yes, sir.
yeah, I was telling about the denial. Denial is actually from the right side. That is what I'm telling. And this can be anything else. Like the patient, like to identify 100 rupees from 10 rupees, you need multiple things. One is your visual. Like the 100
Yes,
rupee
sir.
note and 10 rupee note visually is not same. Not the number. Visually is not same. Second, the size wise it is not same. Right.
Uh,
And third, the idea about that, that is abstract quantity. The idea of the abstract quantity that may not be there. So all these things
yes.
can be affected, and even computation, not just calculation. You can tell calculation when you are giving 100 rupees and you are collecting back some amount. That is not meeting.
Okay.
That is not the balance is not correct. Then it can be most likely to be some calculative error. This may not be calculative. This
Okay,
can
sir.
be when the patient has abstract quantity. If the patient doesn't have idea about what that 100 rupee note is, whether
Yes,
she is
sir.
confusing between 10 rupee and 100 rupees, because 10 rupee notes and 100 rupee notes is totally different in the size, in the color, in the number, everything is different. So even if you
Yes,
don't
sir.
look into the number, you can identify 10 rupee and 100 rupee by the color, no?
Yes,
So
sir.
either
Yes.
it may be visual spatial, it may be visual only. It can be visual.
Okay.
It can
Okay.
be the abstract quantity, the idea about the abstract quantity. Where does the abstract quantity idea sits in or localizes to?
Sir, in left prefrontal cortex, anterior part.
It's actually the calculation. The abstract quantity about the calculation is predominant in the parietal,
Okay.
not the abstraction. This abstraction about the proper abstraction is different. The abstract, the calculation, when you see a like the abstract quantity, 12 is smaller than 14. That idea is known as the abstract quantity, the idea about the quantity. 10 rupee is smaller than 100 rupee. That is abstract idea of that. So that
Okay.
located in the
Okay, sir.
horizontal in part of the interparietal sulcus, hips.
Okay. Okay, sir. One. Yes, sir.
And
Yes, sir. Yes.
yeah, and the word like if you return or the 100 rupees, that is predominantly from
Angular
another area.
gyrus.
Yeah, angular
Yes,
gyrus.
sir. Angular
Then
gyrus. Yes, sir.
and what about the digit? Idea about the digits?
Fusiform gyrus.
Fusiform
Fusiform
gyrus. So
gyrus.
these are the common side. It is exactly not these areas. These are the interplay between these areas helps in the abstract ideas. So this may not be just calculation. It can be visual.
Okay.
It whether it happen only once or it happen very frequently. That is also very important.
Sir,
So to this, anyone can have trouble.
initially it used to happen on the few instances, and then it occurred on the daily basis.
Daily basis. Okay. Whether it is
Yeah.
always 100 to 10 or whether it is other notes also she used to give.
Sir, with the other nodes as well,
Other
20
notes
and
as well.
50.
So your
Yes, yes.
brain has something like pattern recognition. So they can sometimes recognize a pattern of the note even if they don't know the exact quantity. So every time they
Okay,
can give the same notes and they can give different notes. So if it is with different
okay,
notes, sometimes they're giving 500, sometimes giving 50, sometimes giving lesser notes. So that means that he doesn't have any idea of either the note color pattern or the abstract quantity or whatever is written, she is unable to process it or she doesn't have the idea about
okay,
computations and calculations. So what is
okay,
difference between
okay, sir.
computation and calculation? Computation is a complex process. Like you are telling an abstract idea, it
Okay.
requires involvement of frontal plus right side, where you are
Yes,
telling like you have to borrow this much and borrow that much. That is a computational thing. That is again right
okay.
side more dominant. Then the
Yes, sir.
calculation is predominantly like the what you
Left,
written and writing. That
left
is how
parietal area. Yes, sir.
yeah.
Yes.
Okay.
Can I
And
proceed, sir?
whether he has
Huh.
any difficulty in collecting the balance, like if she has given something and she doesn't know how much she has taken back.
No, sir. She pays 100 and she just goes off. She
Okay,
won't collect the change.
that can be abstract idea, that can be judgment, that can be she is unable to identify the
Uh-huh.
that can be anything of that. You cannot
Yes,
convincingly tell.
but just look. Okay, sir.
Okay.
Yes, sir. As a part of her routine activities, she used to fold the clothes and keep in the cupboard, but now makes mistakes in folding. She folds randomly. This was infrequent to begin with, but for the last 12 months occurred on the daily basis. Once she went to the market to buy vegetables, and while
So what do you
returning
infer
home,
from that
she
first one?
lost her way. Sir, here it says that she does remember that she has to fold the clothes, but she's not properly executing the movement.
Yes, okay. Then what it is? Okay, as you told, it's mainly it is executive dysfunction.
Yes, sir, but it could be due to apraxia. But as she is
Why do you think
involving
apraxia? You're telling she's having concept, she's doing the thing, but only she's not doing it properly, right?
properly, yes, sir.
So then why do you want to bring in apraxia?
No, sir. It
Yeah,
is
no,
just
you
because
can, you
they
can tell your idea. Why do you think apraxia is here?
Mm. Because sir, sequential folding can also be affected.
But he is
So
not like
in
multiple steps, right? It's only you're just folding. That is the only step you're going to do, right? That she's not doing it in the proper.
yes, okay,
Not
okay,
like it's
okay,
not like different kinds of steps. When you say multiple steps, it's not like that. Suppose you have
okay,
to fold, you have to keep it there or something. That is the multiple steps. But it's only one thing. She's not doing it in the proper way, right?
okay, okay, sir.
Yeah, and also the beginning you were telling about she was cooking, even she was making extra quantity, even at the proper timing.
Yeah.
So Apraxia to include right now it will be difficult because she doesn't have any issues with
Yes, sir.
using the tools.
Yes,
Nothing was
yes.
there.
Yes, no, no difficulty in using tools. Yes,
Yeah.
sir.
Also the if you like when you are discussing, if you start in a symptom, suddenly introducing a totally different symptom will be more difficult. You can go in the same flow. Like
Okay.
even if you take the note, you can take it maybe either a judgment error. It can also be a judgment error
Yes, yes, sir.
because we already
Yes.
had judgment error.
Yes, sir. She had.
Mm.
Uh,
Somebody asked about computation and calculation. Computation is more complex process. Like you are using multiple complex thing. Like you are suppose you are telling that I am borrowing. If I have 10 apples with me, I am dividing it into two packs. Like is that is actually like it. You use as a complex mathematics, not just mathematics. Using your logical reasoning also. Your data has to planned and screened. All those things has to be done. That is a more complex process. That is a computation. Calculation is simple formula calculation. You're minusing 100 by 10. How much is the balance? That is a calculation. Okay, proceed.
okay. Once she went to the market to buy vegetables, and while returning home, she lost her way.
How did she come back? What did the relatives tell?
So the neighbors helped her to come back. She remembered, like she knew that she had to go the home, but that was her familiar route, but she forgot the way.
So she
She
herself
forgot
asked
the route.
somebody's help and she came back, or somebody just saw her wandering and they brought her home?
Some the neighbors who usually she used to interact with saw her in the market that she was roaming here and there, and so they brought her to the home.
It happens only once, or and any other history of navigation abnormality happen only or just
So
once.
it happened only once, and then the relatives didn't allow her to.
Okay. So so the navigation or you can tell us if you take wandering, how many types of wandering you know?
It is frontal wandering, then it
Yeah.
is topographical disorientation,
No, no. Frontal, then
parietal.
parietal, then epileptic and psychiatric. How
Okay.
you classify those? What is the difference of frontal versus parietal?
So in the frontal wandering, the patient will know the destination. Sorry, in parietal wandering, the patient will know the destination, but
Okay.
will be unable to find the way. In frontal wandering, the
Okay.
patient won't be able to know the destination and will just roam here and there. In epileptic, it
Basically,
is
yeah.
transient. Okay.
Basically, frontal and parietal. Parietal is predominant like something like in Alzheimer's, where, like what you are telling. The patient had an idea. She want to go to the market, but she lost
Hmm.
his way. That is typical parietal
Yes.
wandering. And when somebody like a neighbor asked her, she will tell, "I want to go to this place, but I am unable to find a way." She had an aim to
Find it.
reach.
Yes.
She was planning to go
Yes,
there.
sir.
So
Yes.
aim is there, but she get lost. That is a parietal wandering where the
Yes.
identity, everything, personality, everything is very much preserved. Frontal is where the
Yes, sir.
patient goes out without aim. He will be
Yes,
going
sir.
out somewhere and then he doesn't have an idea to reach any target. She will just wandering, and but she will still preserve her identity. She knows what
Yes, sir.
she is, and her name dot details will be at least present in the initial phases. So that is a frontal wandering. Then epileptic usually again aimless wandering, but personal identity is totally lost, and patient
Yes,
will have
sir.
amnesia. She doesn't remember the
Yes.
event after once she became normal.
Yes,
And
sir.
your psychiatric is where the patient again had aimless wandering. Identity is usually lost, and they have associated other schizophrenia, classically seen schizophrenia, schizophrenic or other psychiatric symptoms. These are the four types of
Okay.
wandering,
Yes.
parietal, frontal, epileptic, and psychiatric.
My question. Okay, sir. Okay.
What do you think is the problem here after the explanation you heard?
So, sir, it started with the judgmental error in cooking, followed
No, no,
by
no, no, no. This I mean to say, she's not able to find her way back home. So how do you interpret that?
yes. So it is parietal wandering, lack of visuospatial knowledge, because she knew that she has to go home, but she wasn't able to find the routes.
So what other questions you want to ask whether to confirm it is visual spatial? Because it happened only once. After that, she did not go out. So how do you confirm that it is visual spatial and not something else?
Does she has difficulty in wandering at the home?
Okay, so does she have that?
No,
How,
sir. At home,
how do
she
you
is
ask
not
that?
having.
How do you ask that whether she has wandering difficulty at home?
वो बाथरूम खुद से जाती मतलब like does she go to the washroom by herself? Does she find a way to the kitchen? Does she find a way to the living room?
Okay. Then other than this, what else you want to ask to know about whether visual spatial function is involved or not?
Is she able to do her basic ADLs like brushing, uh,
No, that can be
bathing?
anything, right? That will not clearly tell you about visual spatial alone. So visual spatial in the sense like suppose how is she eating from her plate? Is she leaving on one side of the plate or not? Or is she able to judge the depth? Suppose something is kept in front of her, is she able to take it from there? Suppose she asks, please, somebody asks, please give me a remote, and the remote is in front of her, but she is looking where it is because she has some visual spatial problem.
Okay. Okay, sir.
So you can ask in the daily activities, how is she able
Yes,
to
sir.
navigate in the home? Not only just finding the room, but sometimes is she
Okay.
bumping into the objects? That also indicates
Okay.
that some kind of visual spatial dysfunction, right? And whether
Yes,
how
sir.
is she
Yes.
serving herself rice or something, dal or something in front of her. So is she able to reach exactly to that item? Is she able to identify that item is in front of her?
Okay. Yes, sir.
Does she have any other complaints suggest of because already we told that she's having difficulty in identifying the notes. Probably one of the possibility we kept is that
Yes, sir.
difficulty in
Yes,
identifying
sir.
the notes, right?
Yes, sir.
Now again you are telling that
Yes, sir.
some visual special complaints. So you can try to elaborate a little more on that
Yes, sir.
when you're taking history.
Okay, sir. Yes, sir. Yes.
And also when she had only one episode, like we cannot tell that definitely whether it is
Oh,
visual spatial navigation, because if it's a one episode it can be something else. So you have to ask whether during the when the neighbor saw her, whether she was conscious, she was able to at least she asked her name and all those things, because it may be
yes.
some other event.
Good.
We don't know because only
Okay,
one
sir.
episode. And
Yes,
usually
sir.
those
Yes.
things which happens, the outside start early and inside home starts very late,
Yes,
later.
sir.
And
Yes, sir.
so inside how she is, outside how she is, whether why she was not restricted to go outside, whether she was going to at least neighbor's home. If they're going to neighbor's home, especially in the villages, they may be going to neighbor's home. So during that,
Yes,
whether
sir.
she had difficulties, whether she was taking too much time, all those things you can ask.
Okay. Okay, sir. Yes, sir.
The other thing
And
you can ask for this visual spatial thing is she able to reach the switches? Is she going to the correct switch or not? Okay, and so
Okay.
that is one of the common mistake. Many times people will tell that they are not able
yes.
to reach the exact switches.
Okay. Okay, sir. Yes.
Also, if you like, not in this case, if you have a case who is having recurrent navigation disability, like you can even ask that whether she was able, like whether he or she is walking with the familiar pathway, whether he is able to identify the shop, or whether
Yes, sir.
he is not able to identify in between the shops are there, but he is not able to identify which shop is that. All those things,
Yes,
not in
sir.
this case. If you have recurrent episodes, you can ask. Single
Yes, sir.
episode, difficult to tell.
Yes.
Okay.
Okay, sir. Yes.
So if it is a visuospatial or like navigation abnormality, where will you localize this?
Parietal cortex, sir.
Yeah,
Right parietal
possibly
area.
in the possibly in the parietal or
Yes, sir.
temporoparietal occipital area. So it's more of network rather than a single area.
Okay,
We
sir.
were discussing about
Okay.
frontal till now. Now this is only symptom which has been in the parietal. Previously it was judgment
Yes.
predominantly. And one doubt in the calculation bar visuospatial regarding the note. Okay.
Yes, sir. Yes.
Okay.
Yes, sir. She also became
And there was no insight to the mistake means what insight
yeah,
about this mistake?
uh means she wasn't uh, sh- means she denied she wasn't aware of that she's making these mistakes. I don't know.
No, you told that previously you mentioned that she is aware of the mistake, And also you told that now she herself,
Means,
she understood that
Yeah.
she lost the way and she asked somebody's help. So again, that is
yes, sir.
contradicting, right? So do you think that she has insight or no? Like that, because that changes many things.
Means
You
she like she forgot to switch off the gas stuff. So when people ask, she said, "I don't know," means I don't remember. So should I
okay?
mention? Means
But
what shall I mention to
yeah,
the?
you
So
can mention when you're explaining those symptoms, because this will confuse. This make me think
Yes,
that
sir.
when I see this whatever you written, I feel like the navigational abnormality which she had, of that she doesn't have mistake. That is what it makes sense. You
Okay,
meant is about
okay,
the initial cooking thing, then you can mention it there. Those things are
okay,
happening, but
sir.
she is not aware of that. The
Okay,
switching of rather than insight, because insight is more of a
okay,
technical term. In history, you better to avoid such terms. History try
okay,
to
fine.
put terms which are more of the words of the patient. So rather than
Okay, sir.
insight, you can tell that patient doesn't remember or whatever it is. You can put it like that rather than keeping it as
Okay,
insight and all.
okay, okay, sir. Okay.
What do you feel,
Yes.
sir?
yes,
Insight,
sir.
whether we should use
No,
should
definitely.
use in history,
As you
I
told
think it
that
is
we
not
should not
good.
try to avoid all these medical terms. And you can tell
Okay.
maybe
Okay,
the
sir.
patient is not aware of her mistakes, that she denies the mistakes. Those terms would be
Okay,
more appropriate, as Sir mentioned.
okay, sir. Yes, sir. Okay, fine, sir. She also became confined to herself, not talking and sitting at one place without interruption. She was an extrovert person before, but she has stopped greeting guests and preferred not to speak unless spoken to since 1 year. She
What does she
stopped
do?
being affected.
Sitting to herself, what does she do? Does she just stare vacantly? Does she watch TV, or what does she do sitting there?
She just stares vacantly.
There
She's
is one
not
more issue.
interested in any surrounding things.
There is one more issue. We are actually telling a story. The initial first two slides, the idea is about the beginning
Yes,
of the illness. So at that time, she was doing cooking
okay.
everything. So she might have been
Yes, sir.
relatively, and even she was going to the vegetable store. So she might have been a better communication at that time. So this symptom might have
Yes, sir.
happened later. So you can even
Was after
actually
1 year.
yeah, that you have to mention, because otherwise this doesn't look fit into the story. Always remember, chronological order is very important.
Yes, sir. She was an extrovert person but had stopped greeting guests and preferred not to
No,
speak unless
first
spoken
line,
to
what do you
since
think?
1 year.
First line, what Sar was asking, what is your interpretation?
Means
And
she's
what she
not
was doing,
interested.
just sitting to herself, not talking.
She's not interested in talking to people. Doesn't like to talk to people.
Yeah, how do you infer that? How do you interpret that?
Maybe she's depressed. Maybe uh, she's not interested. There is no the she doesn't want to socially interact.
So what do you call that? Yeah.
She lack of motivation.
Okay.
Any
So
other like better term? Lack of motivation is a big term.
yeah.
Apathy.
Yeah.
Apathy.
Okay.
So how do you
Whether
differentiate
it
between
is
the depression
apathy
and
or
apathy?
yeah,
Okay, so sir, depressed people are more passive. They'll say ki I'm depressed, and while apathy people are
they may
active,
not
they
tell
would
That
that
I'm
they're
depressed, right?
depressed.
You have to tell how.
They won't
So
tell.
patient is not going to tell I'm
sorry.
depressed. So after hearing this complaint, how are you going to make it out it is depression or apathy?
Okay. Uh, So, sir, depressed patients will be having suicidal ideas. They will
Okay.
have the family history or incidental event preceding the which is followed by
They may
the
not be.
No,
depression.
see, this even the patient with dementia can have associated depression, right? So they needn't
Yes,
have
sir.
any premor like sudden event or family history or anything. They can just have
Yes,
depression because
yes,
of
sir.
the disease itself as a part of.
Yes,
So
sir.
how do you now this patient has come to you? So you need to
Yes,
differentiate
sir.
between these two because the management differs, right?
Yes, sir.
And also our localization also varies to make the diagnosis. So now with the current
Okay.
history, this is a common problem that we always encounter. How to
Yes, sir.
differentiate between apathy and depression. The two close
Yes, sir.
differences. So how do you, what else you want to ask to the patient or the family? One thing you told mentioned
Sir,
is correct.
depressed patient will be. Sorry, sir.
The one thing you mentioned is correct. The suicidal ideation they can have. What else the
Yes, sir.
depressed patient may have?
They will have memory gaps. They won't reply if we'll ask them about remote memories as well as recent one.
No.
While
Basically, depression is a disorder which affect the thought as well as expression. The thought process also will be depressive. See, the
yes, sir.
patient will be thinking about depressive thought. The mood will be depressive. The patient will have vegetative functions like sleep, appetite, everything will be affected. Her expressions will be changed. Her thought process will have depression. That thought process one is suicidal ideation. Everyone will not have suicidal ideation. So all
Okay.
those things will be
Okay.
there rather than just a motor activity or apathy. They will have the entire thought process. Everything will have depressive ideas. When
Okay.
the
Okay.
family members will be able to tell.
The patient can tell that
Yes.
I am sad. So the mood, the effect is
Huh.
important.
Yes.
In
Yes.
that
Yes.
depression, she may be having crying. She may be crying for trivial things, and
Yes.
also, uh, as you mentioned that, as Sarah has mentioned that they'll have other symptoms. Sleep is disturbed. The appetite is
Okay.
disturbed. Okay.
Yes, sir.
And what about this one, the apathy?
Apathy is, sir, lack of motivation, or also known as the lack of energization. Patient won't engage in the hobbies previously they used to. They won't interact with people unless uh, the other person starts to interact.
That is that even same with the depression, right? So what is anhedonia? What is anhedonia?
Uh, there will be lack of facial expressions, gestures.
So patient is not having the interest in the previously pleasurable events, right? Now they are not able to find it
Yes.
pleasurable. Okay.
Yes,
That
sir.
that can occur even with depression. Okay. So no,
Okay.
apathy is more like, as you mentioned, that motivation is not there. So, but to understand that, what are the types of apathy, then we'll understand better. What are the types of
Okay.
apathy?
So the types: cognitive apathy,
Good.
affective apathy, and auto-induction,
Auto activation.
auto-inductive apathy,
Auto activation type. So
auto-activation. Yes.
what is
Yes, sir.
cognitive apathy?
Yes. So the cognitive apathy is, sir, the previously the hobbies which she used to perform, like as in this case, she liked cooking, so she won't cook now, or she is not interested in cooking.
It's
And
not because
affective apathy.
again, it's not because of lack of interest. So the term
Okay.
cognitive type is because she's not able to perform it well. So she'll stop
Okay.
performing.
Okay.
It's
Okay.
more because of
Okay.
the disexecutive function. Okay.
Okay, sir.
So
Okay.
therefore, it will be localized more to the dorsolateral prefrontal cortex.
Prefrontal cortex. Yes.
Now, emotional affective type.
Emotional affective type, like previously, well, she was affectionate. She now she's not a she has
Yeah. So as you told,
she's not interaction.
there is
She
no
doesn't
link between
interact.
the emotion and the affection, the affective signal. So more like suppose somebody
Yes, sir.
dies. Now she doesn't bother. She just sits there. She's not bothered that
Yes, sir.
somebody says that
There's
close
loss of empathy.
died. So that expression, and that she doesn't feel that somebody has died. That is the emotional
Yes,
affective type of apathy. An auto
yes,
activation type of apathy.
sir. That I don't know.
It is more like, see, that as you mentioned, that's the main for the motivation is required for everything, but even for the self-activation,
Yes.
even routine things, the patient will lack severe. It's the most severe form of apathy that sometimes you may be seeing in the
Okay.
ACS strokes, right? They'll be just sitting vacant. They will not bother about anything.
Yes.
You'll be seeing in bilateral ACS stroke patients with any aneurysm rupture or anything. They'll be just awake. They'll be listening to us, but they will not bother about anything. They'll just keep quiet completely. So they will even won't get up or they will not do anything. It is more
Okay.
severe
Okay,
form
sir.
of the one apathy. There, the involvement is mostly at the mesial front.
Yes. Yes.
Okay.
Yes,
So
sir.
now, what do you think it is our patient is having, whether it is depression or apathy? If it is apathy, what kind of apathy do you think it is?
Uh, Sir, this is emotional affective apathy.
The first line itself may be difficult. Maybe after the next lines, maybe we will understand.
Yeah, the second.
So you can
Yes.
continue and you can come back.
Okay, sir. She was an extrovert person before. She has stopped greeting guests and preferred not to speak unless spoken to since 1 year.
Why? What do you think?
Because she doesn't like to, now she doesn't like to talk to people.
So why? What do you think it is? What is localization? Or what do you think of that?
Medial
What is
prefrontal
phenomenology?
cortex.
Phenomenology, like basically, it is maybe just a extension of an empathy. No, right? It's like she was already just confined to herself, not talking, sitting in one place without interruption. So it may be just an extension of empathy only. It may not be. If you want
Okay.
to bring out that it's a personality change, you cannot tell it is a personality, like pure personality change. It's part of empathy only.
Okay. Okay, sir. Okay.
Because you already told that she was confined to herself, not talking, sitting at one place. She is not interested, so she might not be. I mean, when a guest comes, she may not be able to do anything. Like she just will not be having the same empathy there also. No.
Yes, sir.
Okay.
Okay. She stopped being
So
affectionate. She used to.
what are the other amotivational symptoms syndromes? This we have discussed previously also. Amotivational syndromes other than apathy. Abulia
Uh,
and
Abulia and
kinetic
akinetic mutism. Abulia and akinetic mutism. They are the
medicine.
continuum of the same. So
Okay.
abulia, apathy, and akinetic mutism. Yes.
Okay. Okay.
Um, she stopped being affectionate. She used to play with her grandkids, but now doesn't want to and doesn't laugh on listening to the jokes unlike before.
So what do you think that is?
Gradually, again, sir, the she stopped being affectionate. Uh, she uh, she's not able to. There is loss of empathy, and
No, you cannot tell. This is like if you have mentioned the term, you have already mentioned the term affectionate, but this is not just affection. This is like he doesn't want to play. He's already want to confine to herself, not talking, sitting at one place. He had a apathy. These things won't be there.
yes,
This is just part of extension of
okay.
apathy only. So when you can tell that affection, how will you make out empathy or sympathy?
Empathy means previously, uh, with like on the other people's problem with the other people's grief, she would also
Yeah.
join
So
them in their sorrow. But
yeah.
now,
So this history doesn't have that. No, then you cannot tell it is sympathy. This is just playing.
okay,
She had already had lack of interest. So suppose you can ask that the patient, like usually previously the grandmothers and the younger children, so younger kids having fever or some illness, they will be concerned about that. Now they may not be
okay,
concerned about that. They may not
okay,
have that
okay.
rapport with the younger kids. So those things are actually tells you that lack of empathy and sympathy. So where we localize the empathy, sympathy, and all those things?
Medial prefrontal cortex.
Not just medial prefrontal, it is actually circuitry. Uh, this is actually
So ventromedial prefrontal. Sorry.
this empathy, sympathy are actually part of your so-called theory of mind. Those area. So it's
Yes,
actually
sir.
predominantly
Yes.
the frontal pole.
Frontal pole.
Yeah,
Yes.
where
Okay.
where you have the anterior portion of most of the lobes comes in those areas. They're actually not a separate
Okay.
lobe because this is the change of what from the lobe to a circuitry. Because there's
Okay.
theory of mind, the metacognition, all those things resides in the higher cognitive, anterior portion of many of the lobes and its connections with insula and other areas. This is a higher cognitive
Okay.
function. So what are
Okay.
the what are,
Okay.
what are the what are the what are the steps or what are the parts of theory of mind?
Theory of mind means to understand the other people's and state of mind,
Yeah,
and
there are
also
three.
the
there are three phases. I'm not explaining it. Cognitive, conative, and one more is there. I forgot that. There are three steps. Cognitive. One
Okay.
is
Okay.
to an affective. One is to know others' emotion. Second is to respond to others' emotion. Third thing is to influence others' mind.
Okay. Okay, sir.
Okay.
So should I mention these two sentences also, or like while
No,
even in history taking in the exam?
you
So
no, you can add. I can ask the question. How is her emotional link to the grandkids rather than just playing or laughing? Because when the patient is having apathy, they may
okay.
not play, they may not laugh. But like suppose the kid is not well, how she responds?
Okay.
Suppose
Okay.
Suppose the
like
kid
Yes.
plays and falls down, or the kid injures himself while playing, running and falling down. So usually grandparents will be running to them and picking them up.
Yes. Yes.
Or even not only that, even among the household, somebody is fighting with one another. So how are they reacting to that? So these things, as Sar
Okay.
mentioned, those will bring out how is the patient's empathy and sympathy, like how she is able to perceive other people's feeling. You are again, so
Okay.
definitely you can tell these things, but you need to be more elaborate. That's what Sar is trying to tell. You need to
Okay.
be more
Yes,
elaborate
sir.
because we want to bring
Okay.
out the involvement of other areas also. Suppose we already know that she's apathetic, so you needn't again
Yes, sir.
uh, bring out another example. Rather, you need to see that you are
Elaborating the same. Okay.
elaborate other things.
Okay, sir. Okay. I'll take it. Yes.
Okay, then you can next one.
Yes. Okay. Gradually, since 6 months, her speech clarity reduced. She did not speak sentences. While single words were meaningful and appropriate to the questions asked, she had difficulty in comprehending the complex sentences.
Okay, explain.
Okay. Uh, so she could be having aphasia.
No, first you
Uh,
think you told us that speech clarity reduced. So what do you infer
yes,
from?
sir. Could
What
be
do you
due to
what is exactly they mean to say? Like clarity in the sense the word pronunciation you mean here, or do you mean that what you want to convey it is not clear?
word pronunciations.
So if it is
So
a word pronunciation, then is it aphasia then?
see, basically you have used the
Could be due
term.
to apraxia or dysarthria. Means any of the three possibilities could be there. Examination will confirm that.
No, no. Now
I
what is
see
the
you have
possibility? Yeah, sir. You go on, sir.
you had mentioned the term speech clarity. No, that term is doesn't have a clarity. You have to you have to make it more clear and more elaborate. Like what happens during the speech, whether it is he has difficulty in finding words or syllables is not clear. So what is happening has to be more clear. That is not clear in that. Speech clarity doesn't gives you any idea what happens to speech.
Okay.
So can you explain what happened to speech?
There was difficulty in pronunciations.
So if it is pronunciation difficulty, what are the possibilities then? First, let us discuss that there.
Mm, it could be in dysarthria. It could be due to apraxia of the speech.
What is apraxia of speech? And why do you think it's like from history? How do you know that it's apraxia of speech?
From history, sir, if it would have been apraxia, it would have been inconsistent
Yeah, so it's very difficult to tell from history, definitely.
from the
But
history,
apraxia of
yes,
speech,
sir.
as you're telling, see, it is inconsistent things, but it will occur with more complex words, right?
Okay,
The routine words will not have that difficulty in pronunciation with apraxia of speech.
yes, sir.
It's polysyllable words, they will be trying to replace the consonants, right? That is apraxia of speech. Now here,
Yes, sir. Yes.
so you want to bring
And
dysarthria here.
apraxia they will repeatedly. I mean, they can correct it. They repeat it and correct it.
Yes.
Yes, sir. Okay.
So here, do you want to bring again dysarthria again in this patient? No, okay. For now, let us keep dysarthria also. Okay. Then what else? As Sar asked, you need to be more clear. So how
Okay.
is she able to initiate the word? Okay, properly. Is she having any
Yes, sir.
stuttering with the words? how is she pronouncing the words? Is she replacing any words with one another? So you try to tell everything. When you are telling that speech clarity is reduced, is it because the content, the pronunciation, what? Then only we understand the next thing, right?
Okay. Okay, sir.
Yeah, when in cognitive neurology, you're taking a history, where a particular symptom or a phenomenology, you have to keep in mind what all are the possibilities. Suppose the patient is having difficulty to do some activity. This can
Okay.
be anything from visuospatial to a moment, or a weakness or sensory, or patient is having apathy. Anything can present with this symptom. So you have to keep all the DDs during when you're taking and explaining a symptom, and
Okay.
try
Okay,
to
sir.
bring as much as clarity. The same
Okay.
time, try to avoid the technical or the medical terms as much as possible.
Okay, sir. Okay, sir. Okay, I'll take care.
Okay.
This one, as Sir mentioned, so that will be easy for you when you tell exactly the patient words. Okay. So instead of you
Okay.
making a comment like the clarity is reduced, so instead of making that statement, you tell how it reduced. Anything. So
Okay.
you told that patient stopped being affectionate. So you try to tell how that they identify that affection has decreased. So you want the
Okay.
example. If you're telling the examples, never the examiner is going to stop you. So
Okay, sir.
you'll get the
Okay.
clarity always.
Yes, sir. Okay.
In dementia symptoms, if you get an example from the patient, if the patient or bystanders are good historians, then they may tell you now some example of what happened during particular episode. Like you were telling, the navigation was lost in one event. Like such some events, if you get, you'll get much clearer idea, and you can explain those in the history.
Okay, sir. Okay.
Yeah, okay. Then you can continue explaining the remaining.
Relatives notice that she doesn't pay
No, no,
attention
no.
to
The
them while they're
remaining part of speech.
Yeah, yeah.
okay.
Should not.
She did not speak sentences while single words were meaningful and appropriate. She had difficulty in comprehending the complex sentences. Means like whenever they used to say multiple things, she was getting confused in that.
So the first sentence, she was not speaking sentences while single words were meaningful and
Um,
appropriate to questions.
uh, uh,
What do you think?
um, could be her speech output is reduced. Maybe she's
Okay.
maybe she's not like she doesn't like to speak now.
Yeah,
But
just
you see,
you're
until
telling the
6 months
apathy.
back, even though she's apathetic, she was speaking, right? Now, definitely, it is more than apathy. Something else has set in, right?
Her speech output has reduced.
So, definitely, speech output has reduced.
Yes, sir.
But you mean to say that she is giving the exact appropriate answer she is giving?
She's giving appropriate answers, but uh, they're saying काम से काम बात करना means like she's just uh,
She's
whatever
answering what is exactly required, not more than anything. Or she's just telling the words which is required, right? That's what you want to try to tell.
is required for the yes. Yes, sir. Yes.
Okay. But she's having difficulty in comprehending complex sentences.
Complex sentences. Yes.
So, what do you infer?
Like whenever they say multiple things at the time, she gets maybe she's forgetting or she gets confused, but she makes mistakes in that.
No, she's having difficulty in comprehending complex sentences. What do you infer from that? So you're telling they're telling multiple things and she's forgetting. What is the meaning of that? Complex sentence, understanding it. What is the meaning of that? Both are different, right? Suppose you're telling five
Yes,
to
sir.
six things at a time and she's forgetting it. Maybe she's inattentive and how she's having problem with the working memory. She's not able to remember everything in that.
Yes, sir.
But I'm telling a grammatically complex sentence, or I'm giving a complex command to follow.
Yes, sir.
Then
Like when they like when her daughter-in-law asked her to bring the multiple vegetables, fruits, and other groceries, uh, they told that she brought only few, and so they thought that she is having difficulty in understanding, or maybe she is
no,
forgetting.
see exactly as we told earlier. whatever they told you, you should not
Yes,
take
sir.
that interpretation. That example is important. You told that she's not able to bring the multiple items given to her, right?
Yes, yes, sir. Yes, sir.
That is not a comprehension difficulty. If it's a comprehension difficulty, she will not go to the shop itself to bring the items. She will not understand that she has to go out,
Yes,
right?
sir. Okay. Okay.
So you bring out the
Okay.
example always. So if you tell the example, then we can make the interpretation, or you
Yes,
have
sir.
to make the interpretation from what the relatives tell. So
Relatives. Yes, sir. Okay.
if
Okay.
you're bringing again comprehension difficulty, extra areas are getting involved now. Now, if
Okay.
it's only not able to bring the items, the relevant items, she's maybe more inattentive. Maybe she's not planning the way she need to note down, and she has to go and bring the items.
Okay. Okay, sir.
So, do you think our patient has comprehension difficulty or not? Because already you
Sir,
told that one part of the language is involved, like probably one part of the motor component is involved.
yes, sir. As per history, it doesn't seem, but on examination, we'll confirm.
Now we'll confine to history itself.
Yes, sir.
See, you were telling that patient was asked to bring something. So that is not at all comprehension. If she is like it's a language, like Sarah was telling, then the bystander tell that she doesn't understand it. She doesn't go back. When she go back, there is an executive task that requires memory, other executive systems. Everything has to be there to bring something, and memory,
Okay.
attention, everything has to be there. That is a very complex task. It is not just
Okay.
comprehension. And second thing is, if you again that will let you know something else. Like you were telling the patient does not speak in sentences while using single words, meaningful, appropriate. The first thing came to me was apathy, because you already had apathy.
Yes,
But
sir. Yes,
will you
yes.
think apathy will present with this much speaking difficulty? That question is answered by your second part, where you were telling the patient who is seemingly apathetic, who was upon telling with the relative, she was willing to go inside and take something. So that tells you that apathy is not severe.
Okay, sir. Okay.
If that is happening simultaneously, that language cannot be explained by apathy. Because if
Okay.
the apathetic patient went to severe language dysfunction or severe mutism, that means she might be almost bedridden,
Yes, sir. Yes.
almost gone to mutism. Like
Okay, sir.
that, at that stage of apathy, she won't obey the commands and go and take something. So that tells
Okay.
you that apathy is not severe. There is something else is there. What
Okay, sir.
command they are
Okay.
given is more of an executive command which requires attention, multiple
Multiple
modalities.
tests. Yes.
And
Okay.
so the speaking of sentences should be in single words. It is may not be just apathy. There may be some languages.
Okay, sir. Yes.
So that is why you need to assess the entire
Then,
example. That example, when you told, that gives a lot of idea. See, when you
okay.
bring out the
Okay.
examples, that gives you a lot of idea. Then you think in that point of view. So for doing that particular task, what all things is required. Then you
Okay, sir.
change your history and way of writing your history based on that.
Okay.
Because
Okay, sir.
what happens is when you complete the examination, then go back from examination, find to explain your history is actually the wrong way.
Okay.
You have
Okay, sir.
always has to take the history, and from the history you have to have an idea what you will expect in your examination, not the other way.
Okay, sir. Okay. Okay, sir. Okay.
Yeah.
It is very important, the point which Star mentioned, right? Because that is very important, because in exam sometimes you will not be able to get time to do, or the patient may be very much not cooperative. The same day that when the patient wakes up, patient may be very irritable that day. So if patient doesn't cooperate with you, you will not have history and examination also. And also many a times the history is all what we get to diagnose the patient. So as Sar mentioned, history is the most important thing. Then even you can plan your examination by the time you, if you have limited time now, you can go accordingly, which is necessary.
Okay, sir. Okay.
And if you have taken a very good history, even if in your examination you have some faults and you have not done everything, it is not a problem. You will be definitely passed. So the
Okay,
history is
sir.
something which is the initial impression going to create. So history has to be very strong.
Okay, sir. Okay.
Okay.
Relatives notice that she doesn't pay attention to them while they are talking and looks here and there, replying to the while replying to the questions asked. She either repeats the question itself or repeats the same answer again and again.
So then again explain that.
So the first sentence says that she is inattentive. While they are saying her anything, she would look here and there. And the second part says that like she will repeat the same question. Supposedly,
The first line actually, if she's not listening to them, so inattentive, we can tell from the conversation itself, but inattention is more like, suppose she's not following the conversation, it will tell us more about inattention. But she's not listening to them at all completely. Maybe she's not interested in the conversation. Inattention is possible, definitely. But maybe she's not interested.
yes,
She's
sir.
not bothered
The
about
students.
what is going around her.
Uh,
She's not
yes,
bothered about the social situation that is happening there.
yes.
Okay. Then instead of replying to the questions asked, she either repeats the question itself or repeats the same answer again and again.
Same answer again and again. Khana kya khaya? Like as an example, khana kya khaya? Khana kya khaya? Khana kya khaya? She will repeat that.
Okay.
And whenever someone asks कि आप कहाँ रहते हो? बांसवाड़ा, बांसवाड़ा, बांसवाड़ा.
Okay. So how do you infer those two things?
So the first one is known as the equalalia, and the other one, like repeating the same answer again and again, is known as the parietal.
So basically, you think it is I mean, she had a disorder of language or something else. That
It
is
is
actually
the repetitive behavior.
the second disorder of attention only.
Yes, sir.
Perseverations, basically, I think it is more of like she is
Yes,
perseverating the same.
repeating is perseverative behavior.
So equal value, where do you localize?
It is the disorder of language.
Single localization is not there. It is more like in a diffuse area, in speech areas, but sparing the actually sparing both the motor and the sensory speech areas, but the area
It is
surrounding
the
network is involved.
yes, sir.
Okay. Then the perseveration, where do you localize that?
Sir, again, the prefrontal cortex.
Okay. Okay, then you can go on to the next slide.
Yes. Since 3 months, her habits changed, and he has developed aversion to the spicy food which she previously was fond of. There are even instances of eating the non-edible items like paper cups, paper glasses. Later, the relatives also noticed that she started coming out of the washroom without wearing clothes.
Explain the first one. Explain the first one.
Okay. So previously, sir, she used to like the spicy food, and now doesn't wish to eat. Her food habits are changed.
Okay, she has change in food habits. Okay. It doesn't give much of information as per se, like to localize to one area, but food faddism is there, then it will indicate
Yes,
more
sir.
of what is food faddism and
Prefrontal.
what. Okay. Now, but it is not exactly food faddism. She is not interested in particular kind of food now, which previously she was
The
interested.
food.
Okay.
Yes,
Then
so
she was eating the
lack of
non-edible item.
paper cups, like disposable paper glasses.
What do you call that?
Yeah.
What do you call it?
So sorry, sir, I don't know.
What is pica? Okay, so northern pica occurs only in children, right? It can occur.
But they eat the soil while playing.
Yeah, it is basically any non-edible things they're eating. It's
The
called pica.
non-edible item, yes. Yes, yes, yes.
Okay, then.
Relatives then noticed that there were some instances she started coming out of the washroom without wearing clothes, and even sometimes soiled her clothes since 3 months, which occurred occasionally.
What does it means?
Uh, it means that she's not aware. It signifies inappropriate behavior.
Okay. So it is predominantly almost like disinhibition and inappropriate behavior.
Yes,
She
sir.
had also disinhibition. Yeah. So okay, somebody asked about food fads localization. Food fad actually, what I think, like, sir, I don't know exactly. I think it is not a single localization point. It is somewhere in the orbitofrontal with the connections. You cannot tell it a single point.
Yeah, definitely not single point, but if you want to localize to one area, the orbitofrontal cortex may be the best answer. This one, can you continue with the second symptom that she comes out of the washroom without clothes?
Without wearing clothes, and she even sometimes soiled her clothes
So
occasionally.
what is that inference from that?
That she doesn't know whether it is emotional, socially appropriate, mechanically appropriate. So she's not aware whether to do such activities,
She has,
laws of manners,
she has basically disinhibition. That is what you need to say.
disinhibitions, yes, socially inappropriate behavior.
Again, very localized.
Socially inappropriate behavior can be many things. Okay, so you can suppose somebody
Oh,
comes, you can
okay,
fight with them. That is also socially inappropriate behavior only, right?
okay, okay,
But this is basically disinhibition that you need to cover. You are not inhibited what others are thinking, right?
okay, sir.
Hmm.
Uh, yes, sir.
So where do you localize this?
Orbitofrontal cortex.
Okay, so she's soiling her clothes again.
Yes, sir, but it is occurring occasionally, not on
Occasionally.
regular basis.
What are the possibilities? Again, it can be because of disinhibition, but usually disinhibition more like they'll go and void in the inappropriate places. They'll not soil their clothes. That is soiling is more again that can
Okay,
because of more of mesial frontal involvement.
okay, sir. Okay.
Then you mentioned at present she's able to perform her basic activities.
Basic activities, simple activities like bathing, dressing, toileting, and feeding.
So is
Like
Whether
somebody
she
not
is
the
doing
instrument.
doing whether she is doing these activities in the way she is supposed to do.
yeah is somebody supervising her? Is she doing it appropriately or not?
Because she, you already told that she had disinhibition. She is
Yes,
not
sir.
wearing.
Sometimes she is so relatives are supervising her.
So what happens in the bathing? Like whether she was able to put the, like, she sometimes they'll just put water and come out without applying the soap, without cleaning the water off, wiping the water off, without wearing the dress. All those things are already there, no? So her bathing should have been
Yes, sir.
affected. So
Okay.
she is not performing her basic activities now.
Okay. So shall I mention with supervision, or uh,
It's not just
she's
supervision.
not?
You need, as R mentioned, you have to tell because there's significant involvement is there. She might be
Yes,
having
sir.
some mistakes with the bathing, dressing, and also other things also. Like bathing,
Because
uh,
Okay.
is she doing on both sides? Is she just putting water and coming out? Is she applying the soap all over, or is she doing all the steps correctly or not? Somebody
Okay.
has to go and help her or not.
yeah, basically when you have taken the history note, this much you have an idea that what happened to the patient till now.
Yes,
See,
sir. Yes, sir.
the patient had judgment issues, then slowly progressed to severe issues, the attention, then have some language, then had orbitofrontal involvement with involvement like disinhibition. Such patients is very unlikely to do all these activities normally.
Yes, sir. Yes,
Yeah,
sir.
so you
So they
ideally,
mentioned as supervision. So, but I
no,
like
no, you have to, like, whenever you're taking dementia, if you're asking the ADLs has to be asked in detail, like
okay.
especially when the patient had frontal. When the patient has frontal, the ADLs they will tell they will be doing not just supervision, how she is doing each activities,
Okay.
bathing, dressing, toileting, feeding, how she is doing. That is very important, especially
Okay.
when she is taking the food, how she is eating, whether she is eating normally mixing or curries together, whether she is eating like a child, spilling all over, and whether she like previously, especially when females in our society when they eat and finish the food, they used to clean the table and go. That was usual
Okay.
norms. So at least
Okay.
clean the tables. How she is eating habits, whether it is like a child, all those things are very important, especially when you're taking
Okay.
frontal. So you
Okay,
just
sir.
cannot. I mean, you have to. And then when you're telling about the ADLs, you have to have an idea and go back to
Elaborate.
your entire history, and then you have to modify. Otherwise, exam will catch you. That this is grossly
Okay.
wrong from what are you previously telling.
Okay. Okay.
And also you
And
mentioned that she is
AD,
very apathetic. So is she requiring coke? Somebody has to tell to eat. Does she feel hungry and does she ask for food? Does she herself go to bathe, or does she herself go to the toilet? These things also you need to tell.
Okay. Okay.
Only if you know
this is
all
very
this.
unlikely that she does all those things normally.
Yeah.
Yes.
Because
Okay.
after this, at this level, when patient has come to you, that is important. Only if you know those things, you'll know the severity of the
Okay.
disease, and you can
Okay.
help the patient in some way, right? Definitely, we know that
Okay.
dementia patient is not. You're not going to do any wonders for the patient. So you need to understand what is the current functional status. Only then you can help the patient appropriately.
Okay. Okay, sir. Okay.
And ADLs, so how will you classify the ADLs?
So there are basic ADLs and instrumental ADLs.
Correct. Good.
In,
Yeah. So you have to ask, like, when the dementia, if the case performer of dementia is taking, the ADLs are very important. You cannot
okay,
just
sir.
rush to the ADLs. So ADLs ideally you should not ask. There is no need to ask ADLs separately because that is
Okay.
part of your history. When you are asking the
S-
progression of history, that ADLs comes natural in the process of progression. During the stage
so
one,
what,
you were telling about two
like
years
what,
back. You can, yeah,
sorry.
because
So like what should, sorry.
yeah, because like when you were initially, she was even cooking by herself. Even though there was some errors, she was
Yes.
cooking by herself. So she slowly, you can see the progression that slowly she had become apathetic. She has lack of interest. She is not talking much, and then she had even coming out of bathroom. So at that time, you should have an idea that during this period, now she will have this much difficulty. Previously, he was doing bathing and clothing everything by herself till this period. Now she had this in this period, she got support. I mean, assistance from some person. Now she might not be able to do anything. She might not be
Yes, sir.
because this much progression of frontal dysfunctions, she will not be doing this. Bathing is not a simple process; it's a complex process. She will not be doing.
Yes, sir. Yes, sir.
And again,
Okay.
you have come to the present situation before telling all the other relevant negative points. You did not mention them.
Negative history, sir. Like in the later on
So
slides.
there's nothing like negative history separately. So the history, there is no
Okay.
separate heading called negative history. It's only the history you have to tell all the relevant points.
Okay.
You have
Okay.
mentioned almost you have covered all the cognitive domains. Then you have to tell all the relevant negative histories, including the other, like suppose psychotic symptoms, hallucinations, delusions, and
Okay. Okay, sir.
any other negative cognitive complaints in this patient. Then you go on to the other
Okay.
systems like extrapyramidal, pyramidal, and then after finishing all of
So
the history,
with each point, we have to mention the negative history as well.
if it is relevant, suppose your
Okay.
uh, example, you are mentioning about the speech, right?
Yes,
Suppose
sir.
let's say the patient it is an aphasia in this patient. Let us assume. Then
Mm-hmm.
you need to mention that the patient is not having dysarthria there itself.
Okay. Okay.
So the relevant negative history. Suppose you are telling that in the frontal patient is having inattention, patient is having disexecution, and maybe the patient is not having disinhibition. So at the frontal level itself, you can tell that mention that relevant negative there itself. So once
For
you
example,
so
sir,
once you have
continue.
finished, yes, sir.
Continue, sir. Continue, sir.
Once you finish all that relevant history there, and you have covered all the lobar functions sequentially, according to the chronological order you have come up to here, then you need to tell all the other relevant negative history before you come to the present current status.
Okay, sir. Okay.
This is before you conclude the history, you need to tell the current status.
So that's what I'm asking. So the like at current status, what should we mention? Basic ADLs or at the last?
No, you
What to
can tell the
mention that
present functional status of the patient at the end. And before that, when you are telling about a
Okay.
separate support, each symptom, like suppose that is what I'm telling. Like each symptom, if you take, you consider all the possible DDs, no differentials or other areas involved. So those relevant negative. Suppose you are talking about apathy, you have to mention about negative history about depression there and then and there only. Then
Okay.
if you are telling about inattention versus visuospatial, you have to tell the negative history is there only. Then at the end, when you are telling like whatever it was not that much relevant to your symptoms, that you can include at the end. Those whatever relevant to the
Okay.
particular symptoms should be included there only. Because each symptom we are analyzing, you have to exclude everything then and there only.
I think you understood, right, Ekta, Dr. Ekta?
Yes, sir. Yes, sir. I got it.
Okay. Yeah, you can go to the other history.
Yes, sir. And this I've sir mentioned separately. I'll take care from next round.
Yeah, don't
And
never put a heading like negative history. Okay.
yeah.
Okay.
Never
Okay, fine.
put that separate heading. It is nothing separate. It is part of history.
Okay. Okay. There was no complaint of headache, seizures, loss of consciousness, vomiting, myoclonus. No complaint of difficulty in vision, double vision, facial deviation, facial sensory loss. No
See, again,
complaint of paranoid delusions.
excuse 1 minute. Sorry for interrupting, but again, see, you have mentioned that myoclonus here, right? So again, when you're telling the relevant
Yes.
history, you try to group them together. So you have mentioned that involuntary limb movement. So myoclonus is a kind of involuntary movement. So you can put all the
Okay.
extrapyramidal symptoms at a time.
Oh,
Like
okay.
patient is not
Okay.
having slowing of activities, falls. Don't say myoclonus. You have to tell jerk-like movements. As Sar mentioned, you
Okay.
cannot use any kind of medical terms here. Patient is not going to tell myoclonus. So again, the jerk-like
Yes,
movement
sir.
can be anything. Suppose even a patient mentions really a jerk-like movement is there, you need to be very careful what it is. You cannot just directly tell it's myoclonus. You
Okay.
need all the possibilities open.
And
Okay.
and also when you're putting the last part, like you are discussing about a frontal lobe syndrome till now, no? So you are better
Yes,
to
sir.
put forward those negative relevant to that first, like paranoid delusions, hallucinations should come above.
Definitions. Yes, sir. Okay. Okay.
And for myoclonus and all those things, jerky movements and all those things, you can use if you think that is relevant. If you're thinking like after the history, if you think this is a CJD or a CBJD, then you put myoclonus. Otherwise, you just put no involuntary movements is enough, more than enough, because you're not
Okay.
expecting those here.
Okay. Sir.
If
Okay.
you put such words, that means that you're expecting that there. So
Okay.
you can go, you can just organize it. Like if you're taking a history of dementia, put those relevant to those corresponding lobe, like frontal lobe symptoms, you can put it together. Then you come back to cranial loss. If you cannot remember, you can remember the examination order. You can put higher mental function history initially, then cranial loss, then motor, then sensory, and then at the end you go into the etiological things or other associated signs like headache, seizure, loss of consciousness. All these things are associated things. And I mean,
Yes.
for a dementia for such long history, do you expect examiner to keep you a negative history of vomiting? No need. Don't
No,
put
sir.
those things.
Yes. Okay.
That
Yeah,
make it
keep it
like
relevant
loss of
and
the
you group it well and keep it relevant. That is it.
Okay. Okay. Sir. Okay.
try to keep it in order. Like initial history should be
Okay.
related to the dementia higher mental functions. Then you can keep with cranial loss. Then you can keep with motor, sensory, cerebral, or whatever. And at the end, you can think about like etiological point of view, whatever helping you, or other symptoms like headache or seizure, all those things you can put at the end.
Okay.
And
Sir.
like Sir was telling, all the extra pyramidal can be kept together. You have to organize it. That's all.
Okay. Okay, sir. I'll take it. There's no complaint of tremors. I will mention that in front, sir.
Yeah,
Urinary
even
urgency, frequency, or incontinence.
urinary
So,
symptoms is enough, more than enough. Urinary and autonomic symptoms can be combined together in the native
Okay,
history. No
fine.
need to put it separately.
Okay. Okay, fine. There's no
so
complaint of weakness of any limb.
you mentioned that there is no incontinence. But already you mentioned that patient had soiling of clothes.
Yeah.
But sir, in incontinence patient will be aware. In soiling, she is not
No, that is
aware
what
No.
is
that she is doing
incontinence means that
this
patient
behavior.
passes. No. Patient passes urine or stool. Whether either a patient is aware or not, that doesn't mean still the patient is incontinent. Now, what kind of
Okay.
incontinence is that you have to bring out from the history?
Yes. Okay.
Whether it
Fine.
is social
Yes.
incontinence or whether it is
Emotional. Okay.
you have to bring it out from the history. And
Okay.
okay, so here I think anyways we needn't discuss now more about the incontinence. We'll discuss in the next week with the extra pyramidal, but
Okay.
that you don't contradict yourself with your statements.
Okay. Okay. Okay, sir. Okay. There's no complaint of weakness of any limb or thinning of limb. There's no complaint of twitching of limbs. No history of exposure, drug exposure, trauma, fever, joint pain, skin rash. No history of weight loss.
Now you mentioned here that fever, joint pain, and skin rash. What are you expecting in this patient with what skin rashes and mouth ulcers? Which disease is going to occur like this?
No,
Okay.
sir.
Okay, no problem. No history of weight loss. Okay, then.
Past history, nothing significant.
No,
Personal
don't tell
history,
nothing significant.
diet.
No, you never.
Okay.
You tell at least some relevant things. Like, suppose what do you think is relevant in this patient past history? Suppose patient is having hypertension, diabetes. Is it relevant or not?
Vascular risk. There are no vascular risk factors.
That you have to mention here. That is the past history, right?
Okay.
Don't tell
Okay.
nothing.
Okay.
And
Okay,
don't
sir.
mention vascular risk factors. Just mention whatever relevant. Don't mention
Diabetes,
vascular risk factors.
hypertension, hypothyroidism, and what else? Any other things are there? You have to mention that here.
Okay, sir.
Because suppose the patient is having CKD or CLD, is it not relevant here?
Okay. Okay, sir.
Then next slide.
Personal history.
Again, here in the suppose you
Diet,
mentioned that
vegetarian.
I think see this bowel, bladder, and sleep should is part of the routine history. There is nothing personal about that. So personal is actually patient is having the habits like smoking, alcoholism, sexual habits, okay, any drug abuse. So these are the personal things which we have to bring in personal history. Okay. So
And
the
actually, this
bladder
bowel history.
yes, sir. Please go ahead.
Yeah, bowel and bladder should be taken in detail. If she had the symptom, should discharge everything else should be taken detail in the present history only. This is part of cognition only.
And even sleep is also important part of the cognition.
Okay, sir. Okay.
Okay. Okay. Again, family history. Mention any family members are having. What are the relevant family history you want to ask in a patient with dementia?
If the like if another member of the family is having the similar complaints.
Okay.
Or forgetfulness.
Yeah. Sometimes that you mentioned, but sometimes they may not mention that they have a similar history itself. They can have other presentation of the same disease, right? Let's say patients having
like sometimes like headache, stroke, followed by forgetfulness.
Okay, that is more younger patients. You can ask that maybe you are suspecting cadasal or something like that. But here, suppose let's say patient is having apathy, they can have somebody else may have MND kind of presentation. Okay, somebody can have some different kind of presentation than this patient, right?
Variant, yes. Sir. Okay.
So that you need to tell all the other things also.
Yes. Basically, when you have a frontal, especially frontal dementia, you have to ask about like any MND, like Sarah was telling, like they may have some Parkinsonism history, like TSP or something like in the family. If there is some Parkinsonism background is there, or any other person with dementias, all those things can occur in, together in the family.
So we have to mention like no history of forgetfulness in the family or slowing of activities.
No, you can mention no history of any any neurological illness involved, including dementia or extrapyramidal symptoms or any motor neuron disease in the family. You can mention, I think.
Yeah. Here you can use the medical term. You can tell because it's a diagnosis the family is telling. You can tell there's no history of dementia, Parkinsonism. You didn't tell PSP or anything like that. You can tell there's no history of any Parkinsonism or any other neurological disorders.
Okay.
That is good.
Okay. Okay.
Okay, then next.
So can I summarize, sir?
Yeah.
59-year female patient with an insidious onset, gradually progressive, cognitive decline, dysexecutive syndrome since 2 years, behavior and personality changes since 1 year, language dysfunction since 6 months, alteration of the change in the eating preference since 3 months.
So now this may be the slide you made it earlier, right? Now do you want to change anything in this slide after our discussion?
With the visuospatial decline?
But again, we are not sure, right? It's plus minus.
Yes, sir.
Only one episode had there. So as Sarah was mentioning, do you think really the patient has any significant personality change?
No, sir. Only apathy was there. So yes.
So you can mention that definitely disexecution is there. That indicates more involvement of the dorsolateral prefrontal cortex.
The prefrontal cortex.
Then the
Yes, sir.
patient is having apathy. Then the patient is having
Yes,
disinhibition.
sir.
So
Yes,
more
sir.
If you can,
Yeah.
can also explain the disexecutive, like including started with judgment disorder, judgment errors. That those also can
Yes, sir. It
include
started.
because that is very evident.
Okay.
So
Yes. Yes.
okay, then instead of saying it is language dysfunction, you can try to be more particularly what you want to say. Like you here, we are thinking it is more of definitely she has some reduced fluency, some plus or minus maybe.
Yes, sir.
We are not very sure from the history whatever you told, but still
Yes, sir.
thinking whatever you told is correct. You can take it more some kind plus minus some sensory also, but predominantly motor language involvement.
And she also had
Yes, sir.
disinhibition. That is
Okay.
also important. That also
Yes,
can be
sir.
included.
Yes.
Yeah.
Okay. Okay, sir. Okay.
So finally, where do you want to localize now at the end of the history?
So dorsolateral prefrontal cortex, orbitofrontal prefrontal cortex, and medial prefrontal cortex.
Okay.
Could be FTLD.
It's not only just
Or
prefrontal
could,
cortex, but you also have some language dysfunction. Okay.
yes, sir. So
I don't think we got much of
inferior.
any episodic memory from the history.
Yes, sir. Yes.
Okay. Now, at the end of the history, what are your possibilities?
So, sir, it is uh, insidious onset and it's gradually progressive. So it could be likely neurodegenerative disorder.
Directly, do you want to consider neurodegenerative disorder in this case? Because the
and
history is
so
only like 2 years.
could be a reversible cause also, like frontal brain sagging syndrome, but there is no complaint of headache.
See, the frontal brain sagging syndrome can definitely present like FTD, but that is not a very common presentation. It's a treatable cause.
Okay.
Definitely, you can mention that. I agree with that.
Yes.
But
Yes, sir.
you don't say that
Yes.
first.
Okay.
So, at this age of a female, it's predominantly frontal. Even you are not getting temporal also here.
Yes, sir.
Suppose the patient is having a meningioma in the base of the skull. Can it present like this?
Yes.
Is it
Yes,
not
sir.
common?
It can present like this.
Okay.
Yes, sir. Yes.
Then
Okay,
suppose the patient is having recurrent infarcts.
Yes, sir.
Maybe a small vessel ischemic disease, Binswanger.
Yes.
Okay, definitely we did not get other pointers like pyramidal or extrapyramidal here, I agree. But it is again predominantly only frontal, right? We are not getting temporal from the
Yes,
history again.
Yes,
So you
sir. Yes.
cannot bring in directly the FTLD as the first thing.
Okay. Okay, sir.
Yeah, you can actually better is you can tell that after this thing summary, you can tell the areas involved, and then you can go and discuss about the like you can even discuss like I will like to keep these differentials rather than going into one single diagnosis.
Okay.
And always
Okay.
keep including some treatable things. Any
So
examiner will be
treatable thing.
interested to at least include some treatable things in these NDDs if it is possible.
Okay.
Don't
Okay,
just
sir.
confine to one thing. But then you
Yes.
can tell because there's a significant progression and there is no other systems or pyramidal, all those things are involved. So this may be most likely to be, I'll keep this as a first diagnosis, but you can keep the other diagnosis also.
Okay, sir. Okay.
So FTLD, what all things comes out? How will you classify FTLD and what is difference in FTLD from FTD?
FTLDs are frontotemporal lobar dementias. They are classified as behavior. Yes, sir.
Yeah.
It is classified as behavioral variant, progressive non-fluent variant, semantic variant.
FTD. You're telling about FTD. What is different between FTD and FTLD? So
In
FTLD is predominantly it is an umbrella term. Like it includes multiple etiologies. This is basically pathologically it is a frontotemporal lobar degeneration, which can be divided into it can be divided into four groups. One is FTD, second is amnestic variants, third is those with FTD MND, and fourth is
yes, sir.
expanded FTDs. So
Okay,
FTD includes, of which the FTD includes your behavioral variant, non-fluent achromatic variant, semantic variant of
okay,
PPS. Then amnestic variant includes a gyrophilic grain disease and hippocampal sclerosis. Then you have an FTD MND complex.
okay,
Then you have an expanded FTD where you have sometimes with subcortical involvement like PSP, CBD, and primary progressive apraxia of speech. All those things comes
okay,
under the expanded FTDs. So that is FTLD
okay,
is an umbrella term where you can have
okay,
different mechanisms happening. The FTD classifications, what you're telling is behavioral variant, semantic variant, and non-fluent
okay,
achromatic.
okay, sir. Okay,
Because sometimes if you see it maybe frontotemporal, it may be something else. It may not be FTD always.
okay, sir.
Pure
Okay,
pure FTD always.
okay, sir. Okay.
Do you think it is
So,
a rapidly progressive dementia or not in this case?
so rapidly progressive is usually over 1 year.
So
She's
various papers
having,
mention 1 to 2 years, but till 2 years, we can see the patient has
Yeah,
a very significant
okay,
decline within a span of
yes,
2 years. So still,
yeah.
yes,
even
sir.
Actually, Bradley has mentioned 2 years.
yeah. So you need to take it as rapidly progressive dementia because that is important
Okay,
because that covers many of the treatable
the
conditions.
other cause. Yes, sir.
So do you think any degenerative dementias can come with rapidly progressive dementia?
CJD, Creutzfeldt-Jakob disease.
Okay. I mean, okay, that is definitely one, but that is not, that is like more prion disease, right? Like neurodegenerative disease in the sense like AD, like FTD and all these things, which are the which are the ones which can come. Even yesterday also we had same question was like madam was telling, right? Which is the most common cause of rapidly progressive dementia. It is actually AD itself. So the Alzheimer's disease
Okay.
itself can come
Yes,
with,
sir. Yes, sir. Yes, sir.
yeah. So there is definitely AD can. So when do you, what are other causes? What are other neurodegenerative diseases that can come rapidly like in this patient? DLB can come rapidly
DLP.
progressive DLB. Okay. Then we have that
Okay.
even the vascular mixed dementias. Anyone, suppose a patient has AD and have on top of that some stroke, they can come with rapidly progressive dementia. And even
Okay.
FTD can come rapidly, but usually in FTD patients, they'll have associated MND or PSP kind of picture when they come with a rapid progression. A pure FTD progressing very rapidly is little unusual. But in the
Okay,
AD,
sir.
DLB can always come very rapidly. Okay.
Okay.
So in the AD,
Okay.
suppose this is a case of AD, let's assume. Do you think
Yes,
it
sir.
can be
Yes,
AD?
sir.
Suppose AD
Uh,
cases can
like
progress rapidly.
sorry, sir.
Which AD cases can progress rapidly? Which variant of the AD?
Non-amnestic variant, behavioral variant, or disexecutive variant of AD can progress rapidly.
Yes. So it's similar to FTD that can progress rapidly.
Yes,
And
sir.
even the amnestic variant, when it occurs before
In
65
the
years,
younger age. Yes.
to encourage it can progress rapidly.
Yes, sir.
Okay. So
And
we'll
Uh,
like
yes.
when like during the exam for your exams, you always rapidly progressive dementia. This is one of the favorite questions. Somebody asks you rapidly progressive. Everyone knows CJD. There are many other causes.
yes,
There
sir.
is a big table in
Yes,
Bradley,
sir. Yes, sir.
which includes
Yes, sir.
infections like HIV, Whipples, all those things. Then even
Metabolic,
SDH,
toxic.
SDH, SDH
Yes,
can
sir.
sometimes rapidly progress over the 2 months, 3 months. They can progress
NPH
to
as
dementia.
well. Normal
Yeah.
pressure
So also
hydrocephalus.
and even
No,
lymphoma,
no.
some
See,
tumors like
normal pressure
lymphoma.
hydrocephalus you cannot tell in the dementia diagnosis.
Okay.
Why? Why is it so? See, normal pressure
So,
hydrocephalus will not have a prominent dementia as like for them more important complaints are the
will
gait
be
and
gait and urinary incontinence.
and
Okay.
they'll have some subcortical dementia. When they have a
Okay.
significant dementia component, usually there is a coexisting pathology along with the NPH.
Yes.
So
Yes.
isolated
Okay.
NPH having severe dementia is where you not tell it earlier, especially without any other complaints.
Okay. Okay, sir.
And so there are two tables in Bradley, like one is young
Yes, sir.
onset dementias and one is rapidly progressive dementia. At least few of those DDs you should remember. So they will ask
Okay.
at least you should answer at least a few questions, few answers. They are not,
Yes,
nobody's
sir.
expecting you to answer everything. At least few.
Okay.
I think we'll go to the
So,
exam.
sir,
We'll go to the examination because we're running out of time. We'll go to the
okay,
examination
sir.
and then we'll discuss the DDs.
Okay, sir. Examination, appearance well dressed, neat and tidy, mood and affect inappropriate for the situation with inappropriate smiling, conscious, cooperative, orientation to time, place, person is intact, general examination, weight 60 kg, height 165 centimeter, temperature normal, pulse 80 per minute, all peripheral pulses are palpable with no radial or radiofemoral delay or apex pulse deficit present. Central nervous system examination, MMSC is 12 by 30, orientation to place 3 by 5, orientation to time 4 out of 5, registration
No, again,
2 out of
previous
3.
slide you mentioned that patient is well oriented. Again, you are telling here it is not oriented.
But sir, in a place she wasn't able to tell the this city where she was
Yeah, that's okay. But what I'm trying to
staying
say is that
and on the floor.
you can skip those two lines in the first slide. Then it is okay now. So
Okay.
two are again
Okay.
contradicting. You can directly come and tell the MMSC where you want to tell the orientation. That is enough.
Okay. Fine. Registration 2 out of 3, calculation 0 by 5, recall 0 by 3, naming 1 out of 2, reading comprehension 0 by 1, writing 1 out of 1, copying 0 out of 1, repetition 1 out of 1, execution 0 out of 3. Frontal lobe testing, FAB score was 5 by 18, attention forward digit span was 4, TAP A test
What is the
all
normal
omitted,
forward digit span?
it is 7 plus or minus 2.
Okay. Then
TAP A test all omitted along with perseveration of letters said.
so what does that indicates inattention, right?
Yes, sir.
Okay.
A random letter cancellation test was omitted. Concentration and working memory, backward digit span was 2. Planning impaired, a
See,
3-step task was.
when the history, like she had a significant apathy. Whether she was doing all those or she just was skipping it.
In forward digit span, she was able to say 4 like
But the
numbers.
remaining like tap and all, she was simply sitting and tapping, or she was attentive.
She omitted while I was
Okay.
saying A, but randomly she was then tapping.
So she's
Okay.
actually still cooperative with you. She's not very profoundly
Yeah.
affected.
Okay.
So again, that language thing which was there may not be apathy.
Okay. Design fluency impaired. Perseveration was present. Categorical fluency impaired. 2 out of 3. Phonomic fluency was impaired.
How much is phonemic fluency?
3 words.
Phonemic also 3. Okay.
Yes, sir.
Okay. What does that implies? Category is worse than phonemic.
Sir, categorical
The other way,
fluency.
if the
Sorry, sir.
patient, suppose you are saying category is better and phonemic is severely affected, and another
It
patient whose category is severely affected compared to phonemic.
okay. So, sir, categorical fluency localizes to left prefrontal
Cat-
cortex as well as
Category,
the
yeah,
anterolateral
cat,
temporal lobe.
yeah. Basically, categorical fluency is predominantly has some of the temporal involvement. So Alzheimer's patient will have predominant categorical
Uh,
involvement, and phonemic
patient
is
will have
lesser.
impaired
Yeah.
categorical fluency while FTD. Yes, sir.
Here you mentioned that it is impaired, right?
Test for response.
You have to mention, like,
Yes, sir.
suppose
How
don't
many?
mention it is impaired. How many words the patient could tell? Okay.
Okay. Okay.
So always
Fine.
don't directly, as in either in history or examination, to tell your finding, then only you try to interpret that. Don't just tell directly it is impaired.
Okay, sir. Okay. Test for response inhibition. Go no go test unable to perform. Prehension behavior absent by formal testing with the palm test. So this is trail A and trail B test. Trail A time was 2 minutes and 37 seconds. Time for trail B was 5 minutes.
The
This
trail A
is graphical sequencing, Luria.
after
Sorry.
5 minutes, is it completely correct?
No.
So when it's not correct, you needn't tell the time. You can tell it's completely incorrect, right?
Yeah.
Okay.
So if
Okay.
it is
Okay.
unable to do that, no. So both the tests, even trail A is
Huh.
totally wrong, no. She is connected from
Yes,
1,
sir.
2, 3, 4.
Okay.
And the trail B, I think you had a proper format. Trail A also you try to do it in the whatever available format, because the way the number is written is also important, because you have written 6 on one side and
Okay.
5 on another side. And that is
Okay,
actually
sir.
not the exact way to put the trail A. So it's better to do whatever is given in the proper way.
Okay. So we
And
should
this
write
patient, when she,
unable to perform.
yeah, unable to perform, can perform wrongly, no, unable to perform.
Yeah, you can
Okay,
mention
fine.
patient has done, is not able to complete it. Not patient attempted, right?
Yeah,
So
correct,
patient
correct.
Yes,
attempted
sir.
but did not complete it.
Okay, fine. Graphic sequencing,
How did you did the
that
graphic
is,
sequencing?
sorry, sir.
How did you do the graphic sequencing? This both upper and lower, which one is yours, which one is patient's?
Upper one is mine.
So you're supposed to tell the patient to continue from where you have stopped.
Okay.
And it has to be alternating sequence. This is in between, there
Okay.
are three. Whatever your drawn also is wrong. No, at the end you have written three triangles. It has to be
Okay.
alternate triangle squares, and where you had completed, from there the patient has to be continued.
Patient has to continue. Okay.
Otherwise, it is copying. You can see
Okay, sir.
that it is coming together. Like at the end, both the lines are meeting together. If they're closing in phenomena, all those things you can assess by this drawing an additional line below. That is a part of copying. That can be seen in some of the ADs
Okay.
and Alzheimer's and all. But you draw alternate sequence and you stop there, and there the patient will continue from there.
Okay. Okay, sir.
You just go through Scrub and Black if you have. There they have mentioned how
Yes,
to do
sir.
each test. Each test how to do.
Okay, sir.
They have mentioned. Do in that proper way.
Okay, sir. Okay. Uh, Abstract thinking. Proverb interpretation was absent, and she wasn't able to tell the similarities between the table and chair and apple and banana. Motor Luria, uh, she wasn't able to perform with the examiner, and perseveration was present. Temporal lobe testing. Immediate memory was impaired. Recent memory, intact details of the meal, home address, state, new learning ability, impaired as tested by four-letter task. Recall was absent at 5, 10, and 30
How
minutes.
was the
The four
registration?
words were fun, carrot.
How was the
Sorry,
registration?
sir.
How was the registration?
It was impaired, sir.
So when registration is impaired, there is you will not get a recall, no?
Okay. Okay.
Whether she was able to register, then you have to see whether she is able to recall.
Okay.
Because they had to register, then they have to retrieve.
Okay. Hmm.
You
Paired
have to
association. Paired association memory was impaired. Visual memory could find 2 out of the 5 objects.
paired association, or
Episodic
she
and
may not be
semantic memory.
paired association, or she may not be able to attempt. No, she is having so much frontal dysfunction. Don't think
Okay.
she will not be attending.
So
She is just sitting there, no? Most likely. If she is not attending, you can tell the patient is not attending it.
didn't attempt. Okay.
Yeah.
Fine.
Dr. Ekta, this one actually new learning ability. What did you give? I mean, the task for the patient.
The 4 words like fun, carrot, ankle, loyalty.
That is not new learning, right? That is just you're testing the registration. You're testing the registration. That's like immediate memory or registration. You give 4 words, ask them to repeat immediately. That is registration. You ask them to repeat after a few minutes. That is episodic memory. What is new learning ability? How do you test that usually? You give the patient an address, a new address, which they do not know.
Yes.
You give sufficient attempts to make them understand and learn it. Not just once, maybe 3 times, 5 times. You give the address, speak, you tell them, and then you try to ask them the address. That is a new learning ability, right?
Okay.
Now, whatever you have tested is not, it is just you are
Okay.
testing the registration and then the recall.
Oh,
And,
okay, sir.
and when you're
Okay.
writing in the exam, don't write that I'm sure that you have not used one carat angle and royalty, for examination. Because in our patient, that is for those English speaking patients, Our patients, whatever you have
In
used, even if
Hindi, acha. Okay.
yeah, I can either don't write it, just don't write one carat and all those things because you have used something else.
Okay.
So you can just that it is impaired or whatever it is, and when examiner asks what was the letter you had given, you can tell that what letter you had given, not the exact thing what is given to you. And another thing is paired associated learning is otherwise very difficult in normal patients also. So I don't think she might have attempted.
Okay.
Normal, and also you will not take the time to do paired associate learning in examination. It takes a lot
Yeah.
of time.
Yes,
It's not
sir.
possible at
Yes,
all.
sir. Yes, sir. Okay.
So for memory testing, you can just mention first these 4 words. Okay, first like you can give 3
Okay.
or 4 words. At how is the registration? How are they able to recall it at 5, 10, and 30? 30 minutes you'll not be having time, right? Your examination will finish by that
Oh,
time.
yes, sir. Yes, 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 sir.
Okay.
Yes. Okay.
Then you can ask the questions about the remote memory and all. That is fine. Semantic
Yes.
memory, and you
Also the
can
last
ask
one,
the visual
episodic and semantic are written. Episodic you're already tested, is already impaired now. She is unable to
A
register.
remote episode. Episode.
Yeah.
You have changed the words actually. And the other thing is visual memory. How do you test the visual memory? What are the ways to test the visual?
We'll ask the patient, concentrate on the 5 objects, and then we'll hide them, and later ask the patient like where the objects are hidden.
That is one way. And how else do you test? Suppose, see now, why do you want to test both verbal and the visual memory for a patient? Or one is enough?
Visual, like localization changes.
Yes, very good. So for the visual memory, how do you test the registration? So for visual memory, what like similarly as you are given 3 words, you can draw
Yes.
3 simple diagonal. There may be a triangle, a circle, and a diamond. You ask the patient to remember that,
Okay.
and you can ask it after 5 minutes and 10 minutes. That also gives the visual memory.
Okay.
This is more complex one. The
Okay.
one which you are given is a little more complex one.
Okay, sir.
It is also visual memory only, but this is the more simpler test. We need to do both
Okay,
actually to be precise.
Okay, sir. Okay.
Okay, then next slide.
Spontaneous speech having
You
reduced
are
verbal
mentioning
output.
speech in the temporal lobe, right? Do you think
Yes,
speech
sir.
is a function of temporal lobe?
It is both for frontal and temporal.
Temporal and parietal is a very complex circuit, right? So usually
Okay.
what we do is, what we used to do at our institute is, patient needs to be attentive and speech is important when to the remaining examination, right? So once you tell the
Okay, sir.
initial evaluation, you can tell the MMSC, then you can tell the speech, and then you
Yeah.
can go to the
Okay.
attention part.
Yeah. Yeah. Actually, when you start, we
Okay.
are also doing the same way. When we are starting the examination, you have to do the attention, language, even educational status as you mentioned. Then you go to
Okay.
MMC and then you come back here. Now you don't need to
Okay, sir.
repeat it. You can tell already you have already done now. Because with impaired language,
Okay.
impaired attention,
Okay.
the entire examination will be
Mention we
wrong.
can't
Whatever.
examine.
Yeah.
Yes. Okay. Okay, sir.
So what are the things involved in language? You can tell us because we're
Uh,
running out of
uh,
time.
yes, sir. There was reduced verbal output. She was having echolalia. Comprehension preserved for simple commands, pointing commands, and yes or no response, but not for the complex ones. Point to the wall, the window, and your nose. Repetition impaired for long sentences. Naming was impaired. Reading intact, but with comprehension it was impaired. There
See, for
was
the
grammatical.
repetition, you needn't mention it is impaired for long sentences. So our main aim at here to test to ask for the repetition is how is the language circuit. So if you're telling it is for longer
Okay.
sentence, it's impaired. That means that it's used inattentive. that is already
Okay.
established, right?
Okay.
So this repetition is intact when we give only simple sentence, not like a very long. We'll not just first a 3-word sentence, then a 10-word sentence. We'll not go sequentially like that.
Okay.
Just
Okay,
give a
sir.
sentence, patient is able to repeat or not. That's all.
Okay, sir. Writing, grammatical errors present, and omission, paraphrasias were present. Sentence is non-meaningful.
Okay.
मैं Zydus दिखाई.
Okay. So what do you think? What do you infer from this language?
So she is missing the connector words, and the third word is non-comprehensible.
No. Entire after the entire language examination, what do you think? What kind of language dysfunction is this?
It is a motor language dysfunction.
Predominantly motor, because there is reduced
Yes,
fluency,
sir.
lack of grammar. Comprehension is involved, but even the simple commands is able to follow.
Yes, sir. Yes.
Okay. Then next.
Parietal lobe testing. Pantomime was impaired. Imitation of gestures intact. A gesture knowledge could not be checked.
Whether she was attempting all those.
Pantomime, she tried to attempt but didn't complete it. Imitation of gestures she was doing.
So
Gesture knowledge.
basically, when there's a severe frontal, sometimes they may not be attempting. You don't need to mention that's impaired. You can tell the patient's not attempting if they are
Not
not attempted.
attentive. Okay.
Yeah.
Okay. Okay.
That will
Okay,
be
sir.
easy. Otherwise, it will go to other lobes and all.
Yes, sir. Okay. Uh, then sequential action was impaired. Conceptual knowledge was
I
intact.
think she was not doing go no go and all. So I don't think she will be expected to do sequential action and all.
Okay, sir. Okay.
I think she is not attempting all those things because parietal lobe, this looks like a grow parietal dysfunction. I feel she might have some concept. She might have some concept gestures and knowledge. Other things she might not be attempting properly.
Okay. So should I mention that patient didn't attend?
If the patient is not attempted, you can mention patient didn't attempt that.
Pantomime.
She tried. Okay, fine.
Okay. Yes, she tried. Okay.
So the gross thing is from that is the gross idea from that even though if you're thinking the parietal lobe involvement, you can see that the imitation is intact and even the concept is intact. So
Yes,
that
sir.
tells even the real objective is also intact. That means that the parietal lobe is relatively the actually parietal lobe testing is not done this way. You have to do it right and left.
Yeah.
Okay, sir.
Right. We have discussed it previously.
Yes, sir. Okay.
Sir mentioned largely it is intact. Parietal lobe is largely intact.
Okay, sir.
Because even the sequential action, maybe that some inattention is going to contribute to that, right?
Yes, sir.
Maybe
Yes.
don't know how much is able to understand what you are telling also.
Okay, sir. Okay.
The next slide.
Yes, sir. Uh, um, limb kinetic component could make some hand gestures and was able to oppose the thumb and the finger. Calculation was impaired. Right-left confusion on the crossed commands. Stereognosis and cortical sensations intact. No constructional apraxia, dressing apraxia.
So whatever the construction you are seeing, what is that abnormality? You think it is normal?
The first one, the second one. Actually, in fact, everything is
Second one is abnormal. And the third one, the cross is bit rotated and cube.
it's oversimplification.
Yeah, somebody
Yes,
mentioned
sir.
over. So it's basically more of a frontal dysfunction rather than the yes,
even the first one is actually flower pot is actually something it is not copying. No, that is something which
Yes,
you
sir.
tell the patient to do. That is more of the conceptual idea. So that also that is
Okay.
grossly wrong when you compare to other things. Other things when he is copying, it is relatively better
Yes.
when compared to the flower pot. So
Yes,
that
sir.
tells you again it is more predominantly frontal.
First one frontal. Yes, sir. This is the clock drawing. She has again repeated the numbers.
What all errors are there?
The other errors are the crowding of
So
the number.
the first is a circle.
First,
Circle is relatively
the
okay, but
contour. Huh.
then after the numbering, how is the numbering?
Sir, there is crowding on the right side, and again there is repetition of the numbers inside.
So where she
The
started, is she started at 12 or she started at 1?
She started with 12.
So initial task setting was initially normal, right?
Yes, sir.
So the 12 was supposed to, everyone
Yes.
who is supposed to start with 12 only. So task setting initially was normal. Then
Yes,
while
sir.
task monitoring, she had so much errors. That is why she could not,
Yes, sir.
she could not do that properly because the task monitoring went in error. And even she doesn't know the concept
Yes,
there
sir.
because nobody will draw clocks this much like this. So it is
Yes,
not
sir.
a error of construction. It is a error of planning, execution,
Task
and the
planning and
concept.
monitoring. Yes, sir.
And did you ask him to draw any time?
Yes, sir. I asked
And,
her to draw 10 past 11.
and why she has written two numbers inside, two set of numbers repeatedly? Whether she was,
Perseverative behavior.
no, while drawing, what she observed, what you observed, whether he was like, suppose she was initially writing 12 to the inner circle till 10, then she realized that there is no space, and then
Yes,
she
sir.
went back, right? Most likely.
Yes, sir. Yes, sir.
Again, that is a task monitoring error. And then she realized that she
Yes,
could
sir.
not complete, then she came back. That is also tells you that it is predominantly frontal.
Yes,
You get
sir.
frontal.
Yes, sir. Topographical disorientation. Egocentric was intact.
And
Allocentric was impaired.
somebody
Landmark.
has task setting and task monitoring. Task setting is there is not much different, but task setting is predominantly left side, and task monitoring is predominantly slightly right side because it requires visualization.
How did you test this egocentric, allocentric, landmark agnosia in the patient?
Sir, with egocentric, like I asked her to shake her hands with me. So she like did wrongly. While I was giving my right hand, she gave a left hand. She shook her hand with left hand.
Okay, that is, I don't, sorry, do you take that as topographical examination, orientation examination for that? Baishak, sir?
Hello, sir. I
Sir,
didn't hear actually.
do you
Hello?
like, do we take this as examination for topographical orientation?
No, sir. It is predominant. It is not topographical. It is actually like it's more like a body schema.
Yeah, yeah. I don't think we can test basically the topographical
Uh,
orientation bedside liability.
You
okay.
can ask. Only thing is you can ask is where is the door? All those things relating to the inside the room. Then you can even sometimes you can give. I mean, like they're telling about giving maps, but the problem is
Yes, sir.
again culturally in Indian patients it is difficult. That
Yeah.
is possible in outside India. Indian patients it is
Okay,
difficult.
sir.
Then you can ask like at least you can ask if patient is regularly like patient is native of your hospital. Sometimes you can ask that how did you reach the hospital and how to go from this place to that place.
Yes,
That is something
yes,
which
sir.
you can ask,
Yes.
but already has it has a lot of
Okay.
other issues will be affecting that because she already had an
Okay.
executive dysfunction. All those things will affect that.
Basically,
Okay.
you will not be testing this topographical orientation at bedside because that is not reliable.
Okay.
As R mentioned, it has multiple
Yes, sir.
other components also, and we cannot test it bedside.
Okay. Okay, sir. So we shouldn't mention only, no?
We like I don't think it is important to mention because it is
Okay.
not a part of the examination. It is you can get from
Yes,
the
sir.
maybe that's all.
Yes. Okay, sir.
And what we were doing is we just write the topographical this thing heading and then mentioned what we did. Like she was able
Okay.
to identify this thing, that thing, door and the room, and she was able to navigate herself from the room till the toilet. That was what we used to write in the our performer.
Okay. Okay.
That may be a good idea. If you want, you can follow that one. That is definitely.
Yes. Okay, sir. Yes. Occipital lobe testing. No aperceptive or associative visual agnosias. Pyramid and palm
Again,
tree
see,
test was.
you are making some statements like, so there is no agnosia, there is maybe probable so and so apraxia. Don't make those statements. Just
Okay.
need to tell your
Okay.
examination findings, that whatever I examined this one, what did you find out? That's
Okay.
all. Then
See,
when there is a
none of
cross
this.
interpretation, you have to tell it.
See, none of
Okay.
this tests you will be able to do in exam. We cannot
Yeah.
do visual Apraxia and all.
Yes,
You
sir.
cannot do the intent
Yes.
phases, nothing.
Yes, sir.
What you can
Yes,
do
sir.
is
Yes,
just
sir.
field you can do. Then you can do probably color. You can do then some shapes or even prosopagnosia.
Okay.
That much will be
Okay, sir.
something which you can do. Others you cannot do. And even cookie theft, like
Okay.
that, those things you can do because you can carry it and do. And Benton's and
Yes,
all,
sir.
that is something is done by psychologists actually. It's difficult.
Okay, sir. Okay,
You
sir.
can mention the tests, like suppose that you can give the letter cancellation test and the cookie theft sign. You mention the heading, that
Okay.
one, and you can just tell that. Okay. Uh,
Okay.
okay. Don't mention the headings like this double and dorsal and ventral simultaneously present or.
Okay. Okay, sir. Okay.
And this is where your history is going to help you. Once you take in the history, you will understand that it's predominantly frontal and
Yes, sir.
doesn't have much occipital or parietal, and you're not expecting it to happen. If there is a significant
Yes, sir.
dysfunctional that doesn't fits to your FTD, so you
Yes, sir.
can you can if you are not examining also fine, you can tell that the patient is not doing it properly. Something like can tell because you don't get the
Okay.
time to do everything.
Okay. Yes, sir. Yes, sir.
That that is
I
where
know.
if you have a gross difference between history and examination, then examiner will catch you. So always be
Okay.
careful in doing dementia because dementia, even the examiner will not be sit with you to discuss entire examination. They will be
Yes,
after
sir.
history is fine. They will see what are the positive findings.
Okay. Okay, sir. Okay. Cranial
Remaining,
nerve exam.
you can flip it
Yes. Okay.
and come to the conclusion.
Okay.
There are some frontal release signs, right? There are some positive
Yes,
findings.
frontal release signs were positive. Yes.
Okay.
Okay. So
Conclude
59-year-old.
summary.
Yes, sir. A 59-year-old female patient with insidious onset and gradually progressive cognitive decline in the form of executive dysfunction since 2 years, followed by behavioral changes with the change in eating preferences, with impaired attention, with the TAP A test positive impaired
For
planning.
the summary here at the end of the history and examination, you needn't again tell like
Okay,
individual.
all the findings. Okay,
Yeah, you
okay,
can
sir.
tell maybe the patient with a progressive cognitive decline over a period of 2 years with so and so
Okay,
areas involved, because you have finished both the
okay.
history and examination. Now you
Examination.
think
Okay,
what is
sir.
relevant. Suppose some things may not judgment is there, you cannot bring it up in the examination. So, but still it is there. So you can put all
Yes,
those
sir.
things together and you can come to the tell the domains, 3-4 domains involved, and then tell
Yes, sir.
your anatomical localization and the differential.
Okay, sir. Okay. So the anatomical localization is the prefrontal cortex, so dorsolateral, orbitofrontal, and medial, dominant and the non-dominant parietal lobe,
So you
temporal
want to
lobe
give
involvement.
parietal lobe again?
No, sir,
Asking.
I'll change it.
Yeah.
Yes.
And also there
And
is
temporal
involvement of
also, sir,
language.
partially. So,
There is involvement of
yes, sir.
language. So you can include that also. Like you're not mentioned about the motor cortex or the language area.
Yes.
Yeah.
Yes, sir. Yes. Frontal cortex. Okay, sir.
And
So the first differential
and again, and you
diagnosis.
can even tell in such cases when there is multiple lobes, you can tell the predominant involvement.
Okay. Okay, sir.
Predominantly
So,
frontal, like that you can tell.
okay, sir. So, sir, well, like giving the differentials, should we say the treatable causes first? Means even if there is no other suggestive history, or should we directly go to the?
No, that you needn't always tell a treatable. Suppose a patient with let's say 6 to 7 years history patient has come to you. You're not going to
Okay.
expect the patient is going to have any treatable cause, but you are going to evaluate for that. Can maybe some
Okay.
component you can correct it, but it depends again on the history, that period. Suppose this patient has come in 2 years, right? So this
Yes, sir.
history, maybe you have to, you can put some treatable causes if you feel something is relevant. But again, at the same
Okay.
time, some treatable cause, don't put some very rare entity as first one. Or you
Okay.
feel because the picture is more suggestive of a particular degenerative disorder, you can tell that. You keep them
Okay.
first, and then you can tell. But because the period of presentation is only 2 years, and so and so factors are there, I want to consider so and so treatable conditions also.
Okay, sir. Okay. Yes.
Always try to put the DDs rather than putting single diagnosis. Like you
Okay,
can
sir.
put all those things you are considering because, like sir was telling, because of slightly or relatively rapid progression over the 2 years, and
Yes, sir.
under each things you can tell diagnosis. Even if you want to keep, you can keep the you can tell that this one I will keep the first diagnosis or the most likely diagnosis. Then this much things also I had like to rule out.
Okay, sir. Okay.
Yes.
Yes.
Especially in dementia, everyone will be interested about the treatable dementias. Any examiner.
Yes, sir.
Are you
Okay, sir.
considering any treatable things relevantly? Whether like Saro saying the patient is coming 10-year history, fine. Otherwise, in the such 2 year, 1 year, and always treatable should be kept
Okay, sir. Okay.
in the DDs.
Yes.
So, what is the first DD in this case before concluding?
Sir, as you said, like it could be rapidly progressing. We can keep the frontal meningioma first. Then we can keep the degenerative cause, frontotemporal dementia.
Do you think it is frontotemporal dementia?
Temporal lobe involvement is not such.
No. Okay. In frontotemporal dementia, actually, the temporal involvement is
Uh,
little
okay.
lesser, the memory
Yes.
involvement, right?
Yes.
But
Yes.
here,
Yes.
the patient's personality is not very severely affected.
Okay.
So
Okay.
the patient has some disinhibition and all. Okay, definitely FTD is one possibility, but FTD is very difficult in history with after examination. But again, the frontal variant, sorry, the behavioral and disexecutive
Variant
variant
too.
of AD also
Yes.
is equally possible.
Yes, this executive variant of AD as well.
That is also equally possible. Maybe
Yes,
we
sir.
cannot tell which is first more probable.
Okay. Okay, sir.
Okay, and can you tell some
Also,
yes, sir.
also some examiners may sometimes like ask about the domains affected. So you have to keep in mind some may not ask it, but some will ask what are domains affected. Especially, so you have to at
Okay.
the end of the examination you have to keep all those even if you are not writing. To keep that
Okay.
answer ready depends upon the examiner. The
Yes.
question may change. Somebody will ask about only the lobes, but some other person will ask about the domains. So keep ready
Okay.
that those things also in your mind, even if you are not mentioning it.
Okay.
And also,
Okay,
it's
sir.
better that you mention instead of single areas, you can tell always circuit. As R mentioned, no, you
Okay.
can tell
Yes, sir.
so and so circuit. So that is better.
Okay, sir.
Tell that examiner that you know that is not confined to one area.
Okay,
And
sir.
can
Okay.
any other differentials, treatable differentials you can consider? Those it can be rare. Do you want to consider any other treatable differentials for this patient?
Frontal meningioma, then FISS,
What is the other one?
but it
Second,
is very rare.
what is that you told?
Frontal brain sagging syndrome.
Yeah.
Frontal brain sagging syndrome.
Okay.
Uh, then
Which infectious disease can come up with this kind of presentation, like FTD kind of presentation?
SSP,
No, not at this age, definitely, and not SSP,
not
not this.
at this age, yes, not
Not only age, the presentation also not like that.
uh, uh, mm,
Neurosyphilis,
HIV.
HIV,
Okay.
okay, yes, definitely, but neurosyphilis, no, they used to present in the previous years. The presentation is more typical of this severe change in the personality and more of
Yes,
frontal
sir.
lobe syndrome. So that is the
Okay.
classical presentation in tertiary syphilis.
Okay, sir. Okay.
And definitely, HIV is also important other differential to consider. So these are
Yes, sir.
because it's a treatable condition, right?
Yes, sir.
Other
Uh,
infection which can present is also if Whipples. Whipples also sometimes can present,
okay. Yes, sir.
but not
Yes.
this much extreme of apathy and all.
Okay, sir. And sir, other thing, the FAB and MMSC, should we calculate like separately or with the lower testing only we should mention it?
So what we, yes, sir,
Please,
continue.
you can mention it separately. Like suppose you want, you can mention. But what I used to do as a student is that if you're testing MMSC, when you are testing the orientation or calculation, you needn't repeat it again during the lower examination. Either way is okay. But some
Yes.
examiners actually expect that you need to tell that score, MMSC score or
Yeah.
MOOC score, whatever
Okay.
you are doing at your institute, it is okay. But because the
Okay,
score
sir.
will let you know that what are the predominant domains that are involved. Like it's not a completely foolproof, we know that. But definitely people expect that to do MMSC and FAB. These are the important scores.
So like what
Okay,
we were
sir.
doing is
Okay.
we used to take the printout of MOCA, and because
Okay.
MOCA covers the frontal lobe better. Instead of MMC, we were doing is MOCA you are not supposed to do in separate paper. You have to do in the validated size only. The size of square of you are drawing the clock, everything should be ideal. If you do it in a smaller
Yes.
circle, a smaller square, it won't be correct. So, and if the
Okay.
figure you change, that is not validated. So you have to take the validated printout of MOCA. That is what we were doing. And we initial after the general examination, we will write the education qualification. Then we will do the basic attention language. Then we will attach the MOCA. Even the
Okay.
case sheet we used to attach. Then
Oh,
we do the lower examination. That is what we were doing. When FAB, some of the examiners used to ask. But FAB is part
okay,
of
sir.
your normal routine
Frontal
examination
lobe.
also. So you
Yes.
can, there is no need to do it separately, or you can do, if you do FAB, you can finish other part of the frontal examination very fast.
Okay, sir. Yes, sir.
In
Yes.
the Bradley in the neuropsychology lesson, there are many points regarding the MMSC and MOCA. All of you should read
Yes,
that
sir.
for the examination. That will be helpful. What are the advantages? What are the fallacies? Multiple points that are important for the exam are mentioned there.
Yeah,
Okay,
last
sir.
1 minute
Yes.
we will conclude this session. Dr. Baishak and Dr. Krishnamon, you can give final remark, then we'll close the session.
I think Dr. Ekta, you have taken good history and you have done good examination. Only thing there's few corrections that we have mentioned that you
Thank
can
you,
do.
sir. Yes,
And
sir.
the
I'll correct it.
it's
Thank
more
you, sir.
wide open. And not only
Okay,
for
sir.
the differentials, when you tell one complaint and you try to interpret that, you keep multiple options open. Not only for the
Okay, sir.
dementia case, for any neurological case, that is important.
Yes. Okay, sir. Yes.
Good. All the
Thank
best.
you. Thank you so much. Thank you,
And
sir.
Ekta,
Thank you so much.
the thing
Yes.
you have to understand is like I also done the same way I taken the history, same way we had faced the exams. The
Yes,
confusion
sir.
happens in the exam is basically you will be doing lot of examination for a cognitive in the
Yes,
MD
sir.
or DM time, but it will not be applicable to the examination. In the exam, you have to
Okay.
make it simple
Yes, sir.
and handy. So all those unnecessary things you exclude and make a format. Even if you do simple
Yes, sir.
thing, that is more than enough. But the history is most important. History also, we
Okay, sir.
also have done the same way only when we were students, and it is easy to sit on the other side as an examiner
Yeah, yeah.
to tell the problems. But it is difficult to take case, especially dementia. A right way on the exam is difficult. So make it as simple as possible.
Yes,
And
sir.
many
Yes, sir.
times the patient or the exam, the relative may not cooperate even in the exam. We know that all the
Yes.
fallacies, but still, because it is an exam, you have to prepare. So
Yes.
that's all.
Yes. Yes. Thank you. Thank you so
All the best.
much. Thank you.
And you have done very well.
Thank you.
Doing very
Done
well.
very well.
Yeah, thank you, Dr. Baishak and Dr. Krishnamon for moderating this session, and thank you, Dr. Ekta, and everyone for attending this session. And we'll close this session. Thank you very much.
Thank you, sir.
Thank you.
Thank you, Krishna, sir.
Thank you, sir.